You're live.
All right, good morning. This is Senate Health and Welfare, and it is Wednesday, January 21st. We're looking at, we're beginning to take testimony on some of the bills that we're interested in moving out of the committee. So we've got H 237, an act relating to doctoral level psychologists to start us off. And our alleged counsel is not in here, and that's okay. She's been through the bill with us a little bit. And so should be here. We have folks from the Office of Professional Regulations who, why don't we start? There you are. I knew you were wrong. And I understand that you're like to give some preliminary testimony and then that your testimony is longer.
That's for early childhood educators.
Oh,
later.
not for this one. No, it's okay. Good morning.
Good morning. I'm Emily Carr, General Counsel for Office of Professional Regulation. And this is, I'll let the other Emily introduce herself.
I'm Emily Trita, staff attorney with the Office of Professional Regulation.
Good to meet you. We're going to go around and introduce ourselves for you. Because I don't think you've been in here in a while.
Correct.
Yes.
John Morley from Orleans District.
John Benson from Orange District.
Jenny Lyons, Chittenden Southeast District.
Martine LaRock-Ulick, Chittenden Central District. I live in Burlington. I never know if you all know what the districts are. You say these districts, and it's like, what does that mean?
Okay. I live in Williston and I represent all the little rural towns in Chittenden County and a sliver of Burlington.
Incoming's Washington District, Washington County, Stowe, Orange, and Braintree.
Oh, there you go.
Yeah, awesome. Well, it's nice to meet you all. Thanks for having us. So it's my understanding that there are two new members to this committee.
That's right.
So I thought I would go and give a little overview of OPR first. But we just want to thank you for the opportunity to testify on this bill. And we did testify last spring, so some of the testimony may seem familiar, but we'll just refresh everybody's memory. So OPR is an umbrella agency staffed by 40 people and organized under the Secretary of State's office. We oversee about 84,000 licensees in 53 different occupations, including healthcare professionals like nurses, dentists, osteopaths, pharmacists. We also license accountants and architects and tattooists and cosmetologists. So there's a wide range of professions that we oversee. OPR is a public protection agency that accomplishes its public protection mandate by establishing minimum licensure qualifications and enforcing professional conduct standards through its complaint and disciplinary processes. OPR balances this principal protection function against ensuring that individuals have the ability to practice in their chosen professions or occupations without undue government interference. So we really do try to balance public protection with not restricting or placing too many restrictions on the regulation for somebody to be a professional. So now what we're going to talk about, testify a little bit about this bill regarding psychologist prescribing. And back in January 2025, OPR did a sunrise assessment, which examined the scope of expansion proposed in 2021 by the Vermont Psychological Association. So this was to create a prescribing specialty for certain doctoral level psychologists working with collaborating practitioners. And as part of that sunset, OPR reviewed requirements in the 7 states that have already adopted similar programs. In the report, OPR did not support the scope expansion proposed by VPA, but it did conclude that with some modification, appropriately trained prescribing psychologists could modestly supplement the number of prescribing mental health practitioners in Vermont. Overall, the number of practitioners obtaining the credential in other states with much larger populations has been low, However, 4 of the 7 states have newer programs implemented within the last decade. One way OPR achieves public protection in our regulatory programs is by ensuring sufficient preparation for credentials we offer. OPR supports the creation of a prescribing specialty for doctoral level psychologists who have completed the APA designated postdoctoral psychopharmacology degree, passed the national exam, and completed substantial rotations. So this is a perfect example of OPR's typical 3-legged stool of professional qualifications: education, examination, and experience. So OPR does support H237. It greatly improves upon 2021 BPA's proposal, includes many recommendations from our Sunrise report, and incorporates revisions requested in OPR's testimony last year in the House Committee on Healthcare. And just OPR's perspective is like the expansion is going to be very important to all Vermonters. This is going to provide more access and improved access to mental health services, but it's also potentially has the ability to increase our mental health workforce.
So I'd like to comment on a few additional revisions we're requesting to the bill.
Okay, and you do have page numbers or section numbers or?
Yes. And this is also in our written testimony, but in 26 ESA 3001, section 12, the definitions section, we're asking that the committee amend the definition of collaborating practitioner to include not only physicians who have a specialty in psychiatry, which is what the current draft says, but to include other prescribing providers as approved by the board. And that's largely so that we could include primary care physicians, because primary care physicians do the vast majority of psychiatric prescribing. And if we limited this to board certified psychiatrists, it would narrow an already limited pool of potential prescribers. And we would still have the opportunity in rule to set criteria and not have it just be any potential MD or any possible osteopath, but have specific requirements for those collaborating prescribers. And for the nature of collaboration, like the frequency of check-ins and oversight. Those are all things that the current draft would allow us to establish rule. And the other request for a change comes from conversations with both BPA and BMS. So the existing version of the bill requires rotations in 9 practice settings.
Do you have a section there?
Yes, 3019, section B30.
3019, B3.
Yes. So 3019 would be a wholly new section about prescribing psychologists.
Yeah.
And the language asking for 9 rotations over 14 months is something we pulled from the Illinois version of psychologist prescribing, which is we use as a model in many ways. But talking to stakeholders, the point was made that not all of these practice settings are going to be relevant or necessary for prescribing psychologists. Surgery, for example, they're not going to be, nothing about this mode expansion would make psychologists participants in any surgery.
If you don't mind just talking a little louder, I
Oh,
have
yeah.
class behind me.
Okay.
I'm also getting older than everybody else.
And as well as removing pediatrics and obstetrics, the bill, I don't believe currently restricts the ability to prescribe to pregnant people or to children, but that is something we likely would want to limit in rule. And making people do rotations in settings where they would not be able to prescribe to those patients is a hoop, not necessary to make people jump through. The flip side of this, and this is requested in this testimony, but there has been discussion about expanding the months of rotations from 14 months to 18 months. And we leave that to the discretion of the committee, but that's something we would be in support of if you chose to make that change. And you might hear from other stakeholders testifying about that today. Uh, The other last change we would request would be to the effective dates. The timing we foresee for this would be to align with an overall reform we're making to mental health licensing in general. So the main argument against psychologist prescribing that we highlight in our report and have heard is that there's going to be low uptake. Not that many psychologists are going to go get a very rigorous master's degree and take 14 or maybe 18 months out of their professional life to do rotations. And so the question is, why do this when there aren't going to be that many people? And our answer is, why not? Because we're going to be rulemaking anyway within the next couple of years. So the cost to the public of doing this is just the staff time spent rulemaking and standing up the system. And once it's there, it's there. And in the context of doing an overhaul of psychologist administrative rules anyway, it's really fairly minimal. So even if we have one or two more prescribers out there in the field, that seems like a good cost trade-off for us. So the timing we anticipate for that is next session for 2027, we're going to be proposing a full strike and rewrite of the psychologist licensing chapter, along with the other mental health licensing chapters. And this is growing out of a study that we completed at the end of 2024. So that would be next session, 27, and then rulemaking immediately thereafter into 2028. So for that reason, we are asking for the bulk of the bill to take effect in 2029, January 1. So to have rulemaking authority prior to that, have that take effect immediately, but to have this, have the rest take effect then. And the reason for the long timeline, like why do this now and not next session, is because it'll take people at least 3 years to become qualified. If they do this. So if they can spend that time, even though we're not prepared to complete rulemaking, if they can use those years productively, that would be good.
So the 2 days that are here in for section 4A, you're suggesting that in A, it go to 2029?
No, we're suggesting that in B only it go to 2029.
Okay, and A would be at July 26.
Yeah, same as because that way, we can start the rulemaking process before, but then the actual availability of the credential would be 29.
Okay, that's all. Thank you. Questions? Okay,
I'll ask a question. Yeah, is that 29 date at all negotiable in terms of like maybe getting it up and running sooner? It seems as though if we're identifying a crisis, to put it off 3 years is unfortunate. Or have you really like done the
can I ask that question in another way?
short?
If we had B starting in 26. I mean, A starting in 26. What are the implications of A starting in 26? I need to ask that. What does A represent in the bill?
The A is the powers and duties of the board.
Okay.
So it would allow us to begin and to complete rulemaking related to this.
Okay.
And so then it would be operational January of 2020. So I think unfortunately, this is what we think is the soonest it can really be ready to
So
go.
I want to understand that. So, and I think this is where Senator Bulick is going. So you're looking at the full rewrite before you implement the single change of having the doctoral psychologist prescribe.
Yes, because we're doing that anyway next session. And because we'd be rewriting the rules. So what we want to avoid is doing a round of psychologist rulemaking for this alone. That really would, I think, change the balance of costs and benefits of doing this, given the likely little uptake.
So as a former long-term member of LCAR, I understand that there's a process wherein you could put in emergency rules and have a very simplified version of rules and then do a more comprehensive change. I'm just concerned because this bill has been around for a long time, as has the idea. So we'll hold that thought, but does that answer your question, Senator Buell?
It does. Yeah.
Anyway,
Follow up on that, Chair. So as I understand what you were saying, they can start the training and preparation in 26. And that time period here would be about what they would need to be ready to actually implement 29. But the rules governing this wouldn't actually be in place until 29. So what's the risk in them moving forward with what they perceive to be the required training in 26, investing time and resources, get to 29 and find that the rules don't necessarily match what they've just spent the last couple of years preparing for?
That's a great question. And we do anticipate that the lead time could be time people use becoming prepared. The statute, in terms of the education that's required, doesn't leave anything to rulemaking. The proposed bill, I mean, it is laid out saying program is designated by the American Psychological Association. For whatever reason, they use the term designated and not accredited, but it's basically an accrediting program. There are 6 master's programs out there right now for the APA designated. So that's something really black and white that we wouldn't change in rule. So they can, if this were to pass as currently drafted, people could rely on the statute for choosing a master's program because that we're not seeking authority to do anything about that. Those programs, by the way, are the closest one I think is in Illinois, but they all have a virtual option. And the rotations, that's a good question, because you do want people to be able to rely on it. We're hoping that people can get started. The rotations, we aren't seeking, the language that's currently drafted 3019 B3 describes those rotations and what they would be. But that's an excellent question, and we could get back to the committee more generally about effectiveness dates.
good. Yeah, that'd be good. Other questions? Thank you. This has been very helpful.
Thank you.
And we will go back to it as we do markup with our ledge council. So your input will be important.
Thank you.
Stephanie has stepped out. But we need Stephanie Lifters. And then I'm going to ask for one person to leave. Because we have a limit. He just
So
Yeah, okay. We're switching out. Sure.
I don't know if I have the order like you.
Do you want me? Yeah.
I don't think order matters.
Okay.
We heard from OPR and they made some suggestions regarding, which you didn't hear, but maybe.
I think we talked about them last year, is it the
Yeah.
18 months and the smaller number of sites? Yes,
Right.
I addressed that.
And expanding to include primary care folks under the collaborative practitioner definition. And then the date change, they took out, want to take out pediatrics and obstetrics. And then the date change for full mental health system rules changes 2029.
Okay, I think I will address most of that.
Okay, good,
So-
thank you.
Thank you for having me. I'm Stephanie Winters. I represent the Vermont Medical Society. I'm the Deputy Executive Director. I also serve as the Executive Director for the Vermont Psychiatric Association and the Vermont Academy of Family Physicians. I wear a lot of hats, so those are the 3 organizations I'm here on behalf of today. But you'll see me here on behalf of other organizations in the future. For those 3 organizations, we represent over 3,000 physicians and physician assistants across specialties and geographic locations around the state. So thank you for allowing me to testify on H237. as background, we've been involved in all of these discussions regarding psychology prescribing for years. We've participated in the Sunrise Review, conducted by the Office of Professional Regulation, and included submitting detailed written comments, which I did include with my testimony today, what we've submitted to OPR and along with some resources. I will just say on behalf of our organizations, while discussions in the bill language have come a long way, our organizations continue to have concerns regarding the actual benefit of adding more prescribers to Vermont's healthcare system versus increasing access to the much needed mental health services that psychologists currently offer and have expertise in. We've heard this as being touted as an access and workforce initiative, and that's concerning to us. There's no evidence that authorizing psychologists to prescribe medications will increase access to needed mental health services in Vermont. In other states with prescriptive authority, few psychologists have sought such authority, and they've not moved to underserved areas of the state. In fact, across 6 states that allow psychologists to prescribe, there are just over 200 that have sought licenses to do so. We tried to work on our own chart and pull all of the licensing data from states, and we created our own chart, but then found a great illustration, which is included in my testimony, from the Society of Clinical Psychology, which mirrored our calculations, and that shows the different numbers of psychologists, the number that have actual prescriptive authority in 6 of the states. There's a 7th state, Utah, which they don't. We couldn't find numbers for yet. They just passed in 2024. If Vermont followed the ratios of practitioners to population, we would expect to see 1 to 5 prescribing psychologists in 5 to 10 years. There are already a breadth of prescribers who receive extensive medical and psychoactive prescribing training. I have a couple of them here today with me. Just to introduce, I have family medicine residents in the room for their advocacy morning. They're just getting a taste of the State House today. So physicians other than psychiatrists now receive more psychoactive prescribing training. The number of medical schools has increased, and psychiatric residency programs have expanded from 183 in 2011 to 352 programs in 2022. Nurse practitioners, or APRNs, and physician assistants have training more closely aligned with prescribing than psychologists do, and their workforces are growing faster, with more training programs poised to train yet greater numbers of prescribing professionals. And then there's a chart in my testimony that just shows the different levels of those prescribing professionals and their numbers compared to population. So I think I reference an article in the Prescribing Psychologist, the Society of Clinical Psychology, titled "The Prescribing Psychologist Workforce: Enough to Matter or Worth the Cost?" And I'll just say that in the end, they say their solution is collaborative care. Psychologists are well equipped to work alongside psychiatrists and other physicians, nurse practitioners, and PAs in their interdisciplinary teams. And by leveraging their strengths in psychological assessment, psychotherapy, consultation, and research, psychologists are well positioned to contribute to comprehensive patient care that addresses both psychological and pharmacological needs. We strongly support that method and that recommendation, and elaborate further down in the testimony on methods to expand access to collaborative care in Vermont. And I think I have a portion here on psychiatric medications. I am not a clinician. I should have said that right up front. I represent those who practice medicine, and I know there are a number of them who would love to come in and talk to you about the clinical portion, but I will just say that there are concerns regarding safety and training, especially around psychiatric medications, which are among the most potent in medicine, and they affect the entire body. So would love to have more opportunity to bring in psychiatrists and other health professionals to talk about that. A peer-reviewed study of psychologists prescribing found there's no data to suggest that providing prescription privilege to psychologists will increase access to quality psychiatric care. This is particularly disturbing in light of the fact that psychologists have been prescribing for more than a decade in some areas. Current psychology programs are highly variable, and the training lacks some of the preparation in basic sciences, chemistry, biology, and physics, which are required for clinicians prior to medical APRN or PA programs. So I will say access to mental health and psychiatric services is a legitimate concern in Vermont. The good news is that there are evidence-based programs and answers that address access to care while maintaining sufficient or advanced practice professional prescribing. And many of those are already happening in a limited way, and expanding them would be significant to the health of Vermonters. So these include the Blueprint for Health. As you know, there was a pilot to assist practices to address mental health, substance use disorder, and social determinant of health needs. The pilot was not funded last year. They are working still based on carryover funds, but beyond that, there is no funding, and that includes the Dulce program, which is the family specialist in every 0 to 6 month visit. We need to increase retention and recruitment of psychiatrists in Vermont. And unfortunately, we heard yesterday, my first bullet is enhancing loan repayment for psychiatrists, but unfortunately, we heard that part of the governor's recommend in his budget is actually cutting loan repayment for physicians, for nurses, for PAs, for a whole realm of practitioners. And so that is very concerning. Reimbursing psychiatrists and primary care practitioners consulting with each other. So currently there's no payment for that, to be able to work together in a team-based way to help a patient. This is included in the Rural Health Transformation Grant. So we're excited about that. Increasing access for primary care practices to collaborative care models. So that is where a primary care practice can phone a friend. So a great example of this is they just changed their name. The Vermont Consultation and Psychiatry Access Program. It used to be the Child Psychiatry Access Program. So pediatricians, family physicians can contact this program. It is staffed by an interdisciplinary group, and they help that primary care take care of that patient with their mental health needs. That could include medication, that could include referrals to services, and the patient doesn't have to leave their medical home. And so increasing that to the adult population through grant funds, it's an amazing way to have that team-based care model. And speaking of primary care, supporting S197 and investing in primary care, because we know that up to 75% of primary care visits include mental and I know we're not supposed to use this word, behavioral health components.
So we could use it
determinant-
because we have a definition of it.
Okay.
Do it.
Okay, good. So S197 will increase the percentage of healthcare spending invested in primary care, reform the way primary care is paid in the state to decrease burden and increase access. And you will hear more on this and our views on this from my colleague Jessa Barnard tomorrow. And then finally, support funding for this Psychiatry Advanced Practice Registered Nurse Program at UVM. This would allow for more nurses in Vermont to receive advanced practice training. So now the language of the bill. The bill as passed, the House does include safeguards with additional standardized training, including the completion of a postdoctoral training program in psychopharmacology. We actually would recommend to add to the OPR rulemaking to establish a minimum requirement for curriculum of a designated postdoctoral psychopharmacology program. So
which section is that? Section.
It's under A3. So I don't have the section number on here, but the board shall adopt rules necessary to perform its duties under this chapter, including rules that regulate prescribing psychologists, licensees pursuant to section 3019 of this title. So A is the settings of the clinical rotations, and then we recommend B, the minimum requirements for curriculum of a designated postdoctoral psychopharmacology program.
Got it. I think the numbering is different as
Okay.
past the house, yes.
Okay. We have reviewed OPR suggested language on clinical rotations and agree with an 18-month clinical rotation to include, and I may have these wrong if they've changed since last year, but to include psychiatry, geriatrics, family medicine or internal medicine, emergency medicine, neurology, and one elective. Is that right? Okay. We believe this moves forward that this is critical in providing some valuable medical knowledge and skills. And then having a collaborative practice agreement with an MD or DO who specializes in psychiatry. We feel strongly that this be a psychiatrist. Having a psychiatrist specifically is crucial because they possess the specialized knowledge and training to diagnose and treat mental health medical conditions with expertise in prescribing psychotropics. And to
Okay,
just,
so where does that go? I'm trying to, because going through the bill, but I don't, I think it's the collaborating practitioner, one of the recommendations from OPR was to add primary care. So
Yeah.
you're suggesting not to add primary care.
correct.
Okay, that's all. Okay.
So in conclusion, psychologists are experts in important mental health interventions and are highly valued members of the healthcare community. While this bill does incorporate safeguards, we continue to be concerned about diverting important time and resources away from professionals doing what we need more of, which is not prescribing. We are also concerned that we're going into this for the wrong reason. This is not a solution for increasing access to mental health. And we do already have important programs that are being cut, partially funded, or not fully utilized to support patients. Again, we do have a number of psychiatrists and family physicians interested and willing to testify, and we hope that we can make space in your agenda to hear from them. Thank you.
Thank you. Questions committee. I'll ask a question. This is helpful, but before I ask questions, I want to say welcome to our visitors. This is great. So wait, so what are these are residents or
Family, yep,
and family practice?
Yep, there's 3 of them.
Glad you're here. Glad you're doing what you're doing. Really important.
And stay in Vermont.
And stay in Vermont. Please stay in Vermont. And my editorial comment is I'm going to work very hard to keep AHEC funding. It's so critical to our workforce. So I was actually surprised about that omission, but we'll see what happens. I do have a question. So I have heard from folks who have a prescription from a psychiatrist and it's an ongoing prescription. So then, as you know, many of these prescriptions are 30 days, then you have to go back. And sometimes it requires an extra visit or it requires going to your psychiatrist at the same time that you are in counseling or work with a psychologist. And the comment that was made to me is, well, if I could just have my psychologist renew my prescription, my life would be simpler. And I can see that I can see that for this type of drug as well as for others. And I know the stress that some people go through just to have to go back to this doctor. Anyway,
I mean,
so your thoughts on that?
my answer would be, I hope that, especially if we invest in primary care, that people would have access to a primary care clinician. And then the primary care clinician, and I could phone a friend around the room, but that a primary care clinician could be that ongoing renewal of medication. And they currently have the training, the appropriate training to do that. And so there's a coordination between the two.
Okay. And to play devil's advocate.
Yeah.
Maybe I don't go see my primary care 4 or 5 or 6 times a year, but I do see my psychologist that number of times. So that's
I
all.
hope you don't need your medication renewed 5 or 6 times a year.
Well, depends on.
Change maybe,
Yeah.
but
Yeah, okay.
Yeah.
This
my psychiatrist will be happy to answer those questions.
I would like to hear that. I think
Yeah.
because that's really a point that's been brought up that I can empathize with a little bit.
Yeah.
Yeah. All right, other questions? Say you got, put you in the hot seat. Mr.
Jenny, I wasn't expecting that from you. Thank you.
All right, is Brandon Campbell here?
By the window.
Yes, it's
All people,
Oh, okay,
it was a very big bird,
huh?
a very large bird, probably an eagle, just flew by them. Really,
That means, or it could be a snowy white owl because it's getting cold out.
I've never seen, there is an eagle that haunts
There-
Winooski. I did see a biggest hawk I've ever seen, or a young brown eagle. A tree by the interstate.
I know, they're up in the woods, so it's,
I have seen them here.
oh, neat. We're being taken care of. All right, so, is Dr. Campbell, Brent, Brent, there you are. Welcome.
Thank you for having me.
We're gonna get all the sound turned up on, can you just state your name for the record so we can hear what the
Yep.
sound?
Sure. My name is Dr. Brandon Campo.
Perfect. Why don't you, then introduce yourself for the record and we'd like to hear your testimony.
Sure. My name is Dr. Brandon Campo. I currently practice in Stowe, Vermont. I specialize in neuropsychological assessments, you know, in addition to autism and a few other things like that. So that's who I am.
Okay. Your testimony.
Yeah, you know, so this is my second time coming before the committee, you know, with regard to having psychologists have prescription privileges in Vermont. Hopefully, Vermont will be the 8th state, you know, that does this. And it's not a secret, you know, there is a psychiatrist shortage, you know, nationwide, you know, between somewhere, the numbers say between, you know, 14 and 31,000. You know, as it pertains to Vermont, yeah, you know, they're going to need a 13% increase, you know, by 2030, you know, and that, you know, increase currently puts a strain on the system and other providers, you know, particularly in rural areas, you know, but we're not looking to have Vermont, you know, as the wild, wild west and just write scripts all over the place. You know, we have a lot of non-pharmacological approaches as well in our toolbox. And this is just another tool in the toolbox. You know, if the only tool in your toolbox is a hammer, well, then guess what? The whole world looks like a nail, you know, and I do hear a lot, you know, after I perform a neuropsych eval and, you know, the patient gets the appropriate diagnosis and I make a med recommendation, I do hear a lot of the times, Brandon, this is all well and good, but I can't get in to see my psychiatrist for, you know, 3, sometimes 6 months, or, you know, they're not taking anyone. That's a tough pill to swallow, you know, literally. So then what do I tell these patients? You know, suck it up until you can get, you know, get in, you know, 6 months later, or can I help bridge, you know, that gap? You know, the other piece too is that rather than, you know, seeing your psychiatrist, whether it's once a month, you know, if it's a controlled substance, or for a 3-month checkup, we see our patients every week for at least an hour. So we are able to monitor their progression, you know, on the medication. And if it's not working for them at that moment in time, we can, you know, adjust and shift gears rather than having to wait, you know, another month, you know, to get in. You know, so like I said, you know, 7 states already do this. I'm hoping Vermont will be the 8th, you know, and with this expansion, you know, it has led to, you know, potential solutions for mental health, you know, particularly in rural areas. And that's not me saying that, that's the APA, you know, and in addition to that, it has decreased suicide rates, you know, as well. So I'm a huge proponent, you know, of the H237. And I think in the long run, because I want folks to think, you know, that this is a marathon. This isn't a sprint, you know, and this is only one part, you know, of the pie, so to speak, you know, in addition with our other, you know, collaborative partners. You know, I talk to, primary cares, and work with other, mental health providers all the time. And I do hear that I'm not comfortable, prescribing a psychotropic med that's a little bit out of my wheelhouse, and I'll refer to a psychiatrist. And that's fantastic if there was a whole bunch of psychiatrists on deck. Unfortunately, they're not, and Vermont has an aging population, as well. So, so that's my 2 cents, folks.
Questions? Can you get your testimony written, and send it to our committee assistant so we have it on record?
Yes, ma'am.
That would be terrific.
Sure.
Any questions? So, you heard my question previously regarding sort of the update to prescriptions. Is that something that is a concern to you, or that you have with any of your folks in your practice?
I'm sorry, what was that update, ma'am?
The question is, I've heard from patients that frequently they're given a prescription by their psychiatrist, but they are in ongoing counseling with their psychologist, and they would find it helpful to have the psychologist update their prescription. Is that something that occurs with your patients?
I do hear that a lot. That, they'll come in and they'll report they're having, some sort of an issue with their med, whether it be a rebound effect or whatever the case may be, and then they cannot get in quick enough to see their psychiatrist. So if we created, essentially a milieu-based system, not only would they be able to come to us, we would be able to then monitor and track their medication as well. And if an adjustment then needs to be made, we can do it right then and there, And I'm also a huge proponent of not working inside of a vacuum, So a lot that goes into this is collaboration, So with a lot of my folks, I have the release of information to speak to their primary or whomever is their current prescriber. And that takes time too, and folks aren't coming off their mountain to come see their neighborhood friendly psychologist, and that's the issue too. We don't want to be a barrier, for them accessing, their healthcare. We want to be part of the solution, not add to the problem. And I think, going back to what you were saying, yes, I do hear that a lot, and I think this would be one less barrier for those folks, particularly the folks, in the rural areas. So sure.
Okay, and then you also do work with their physician, their psychiatrist, or others in sort of communicating.
Yes, ma'am.
Are you part of any electronic health record system where you are?
Well, the only the electronic health system that we have within the practice is one that is of our own. It's not like you go to CVH and they punch you into the system and boom, everything is there. No, nothing like that.
Thank you. Any other questions? Okay, thank you very much for being here this morning. We appreciate it.
Thank you, folks. Thank you for having me. I appreciate it as well. Thank you.
And so we have Rick Barnett, who's here from the BPA.
Yes.
We have lots of BPAs in our state.
Yes.
And we have your testimony. Okay.
Yeah, for the record, my name is Dr. Rick Barnett. I'm the chair of the Vermont Psychological Association Legislative Committee, and a clinical psychologist in private practice in Stowe, and have been practicing for over 20 years. I want to thank Representative McClellan for spearheading this effort with this bill through the session last time, and here we are in Senate, hopefully passing it out. So thank you very much, and to the House for passing it unanimously last spring. And as Dr. Campo mentioned, it is definitely a marathon, not a sprint. For those of you who are new, this bill has been presented in this building for 10 years straight. We've had a bill, and this bill has been modified substantially. We've heard about all the requirements that are embedded within this bill, and that's because of the great work of the Office of Professional Regulation, who you heard testimony supports this bill with the added safeguards, which are, I agree, are substantial. So you know my stance on this bill. I'm very supportive of it. I'll just go back to some of the points that have been made so far. First off, with the date that Senator Gulick had mentioned, pushing it back to January 1st, 2029 is, knocks the wind out of my sails a little bit. But as you had pointed out, there is a lag time for rulemaking and to get the education. So just from a workforce perspective, there's one psychologist in the state of Vermont right now who has the required training minus the clinical rotations. That is me. There are other psychologists across the country who I'm in contact regularly who are happy to move to Vermont to become prescribing psychologists. So our workforce could, in fact, be substantial within the next few years should this bill pass. But again, there is a 2-year process to get your master's degree in psychopharmacology after you have a doctorate. Okay, so a 5-6 year doctoral degree with a license, and then a 2-year master's degree on top of that to be able to work towards having prescriptive authority. So if this passes goes into effect July 2026, someone says, okay, fall of 2026, I'm going to get my master's in clinical psychopharmacology. So by the spring of 2028, they're finishing their master's degree, and this rulemaking process goes into effect 2029. Okay, that's reasonable. And there's going to be people coming into the state that will say, oh, I want to move to Vermont and I want to get this training, or I'll do my clinical rotations in Vermont. So yeah, it's a long time, but again, we've had this bill for 10 years. And if this makes it over the finish line this year, it's a win for us. In terms of the line in the bill, whether to strike or to keep with a specialty in psychiatry as a collaborating provider, again, under definitions, collaborating provider, we strongly suggest that we strike with a specialty in psychiatry. It is necessary for this bill to be successful, for this workforce to be successful, to not be limited to only psychiatrists as collaborating providers. We've heard that most psychotropic medications are prescribed in primary care. Primary care physicians are highly qualified to supervise the prescribing of psychotropic medications. There are complex cases that primary care clinicians, of course, refer to psychiatry. And in those cases, it's a team effort. This is definitely an integrated care bill. It's not a silo bill where prescribing psychologists go off here and do their thing, and we're all working together. This bill brings a lot of things together. To your point, Senator Lyons, that happens all the time. You have to go see your primary care physician for that, your psychiatrist for that, your psychologist for that. So much can be done in a psychologist's office that prevents people from having to schlep over here, the copay over here, the copay over there. It's ridiculous. So it's just a small little thing that we can do to help people not have to travel around like that. And then finally, with the clinical rotations, super happy to have those 9 rotations reduced to 5 or 6. That's fine. If we can leave it at 14 months to not add an extra 4 months on top of those clinical rotations, that would be great. But we understand that, safety is a primary concern for our psychiatry colleagues. And if that's the hill we die on, that's fine. We'll just go with 18 months. But as it's written in the bill, 14 months is fine with us. And I'm happy to answer any questions you might have.
Questions? Go ahead, Senator.
I guess it's just come up to me with the previous witness testimony that you don't have access to the medical records of so when someone comes to see you, you don't have that whole, I showed up at the ER on Saturday and they put me on this drug, and I also have diabetes, and so that information can be crucial to making a right diagnosis. How is it with the consulting physician? How are you going to know the medical issues with your patient client.
Yeah, there's a long runway here, so I think there's a couple of things there. One is definitely with the collaborating provider agreement, which is a way that prescribing psychologists would naturally have access to whatever their supervising provider has access to in terms of the more robust interconnected technology systems. But again, with a long runway, my hope would be that anyone who becomes a prescribing psychologist could, in fact, be able to apply to link up with these systems so they have access to that information for sure. That's very important. But I think having a collaborating provider collaboration requirement is something that helps people. A prescribing psychologist working with a patient who's got diabetes, hypertension, and a host of other things that is on a bunch of medication isn't going to unilaterally just prescribe a psychiatric medication. Oh, take this. It's always going to be in collaboration with the provider. So that's a great point.
But right now, you could set up a collaboration agreement with a primary care doc who does most of the prescribing. That's possible under the present system, right?
I've tried. I mean, I was part of the whole Vital rollout years ago, and that didn't work out too well. I was entered into their system as somebody to be able to access stuff. eClinicalWorks is the thing in LaMoille County that people use. I've tried to get access to that. It is a little bit difficult right now as it is to access Epic or any of the other electronic health records that are part of UVM, the UVM system, but I guess it could be something to be looked at.
But if you had a collaboration with a primary care doc. Okay, but all your patients would have a different primary care doc. So, around here, part of the UVM network, they seem to have everybody in the same building. And they'll send you down the hall to the dietitian and the psychiatrist. And it sounds like in those situations, you would have that collaboration where you could call down the hall and say, I've got this patient, I'd like this. You might get a script.
Yeah, I think with the prescribing psychologist bill, it gives a lot of flexibility for someone with that designation to be able to join a primary care practice and join the team, and then therefore be already automatically entered into the electronic healthcare system or work independently with a collaborating agreement and then maybe get access to that way.
Take care.
That help?
Yeah.
Other questions? Okay, well, this is our first crack at this bill. Well, it's our second. We started it last year, as you know, and it's a holdover, but it is one that we're going to look at again. So we'll take more testimony and put it on the agenda. Okay.
Thank you.
Thank you. Well, we're a little behind, but that's okay. We're gonna move right on to S-157, the recovery residence certification. With Katie.
Can't bring any easy ones, can you?
What do you want? You need a break? Oh, there we go. There we go. We got the. Oh, Emily, true. I've been wanting to see you. Hi. We're still alive, but I'm gonna ask you a question about how much we save. Remember the question I asked you about savings with prevention?
Yes.
Have you been working on that?
So there is a dollar figure that's understood at the national level.
I'm gonna let you, we'll talk later.
Okay,
We'll
good.
get that information. I think everybody will be interested.
Okay.
Thank you.
You're welcome.
All right, welcome.
Thank you. Good morning.
So thank you for being here. And we did go through the other bill without your presence, but there were some suggestions made on specific sections. So when we get to a stage of markup, I think we got most of it and it's in testimony. We can talk about it.
Okay, that sounds great.
And so now it would be helpful to walk through 157, a little deeper dive than from what we did previously. And I know that, as we said earlier, Department of Health and AHS had recommendations, and we'll get to them.
Okay, that sounds great. Katie McLean, Office of Legislative Counsel. This is our bill on recovery residences and the certification. We did sort of a high level overview of this last week. So if you remember, the first section of this bill has to do with certifying recovery residences. This would be a voluntary program. So first we have a definition of what we mean by recovery residence. It means a shared temporary living residence supporting persons recovering from a substance use disorder that provides care through care support and assistance accessing support services and community resources available to persons recovering from substance use disorder.
So,
And this is I apologize.
go ahead.
This is a variation of a definition that is currently in statute. It's just moving to a new location.
So the question I have, and it's probably for the folks in the room, is that there's no definition here of the various levels of recovery. And I'm wondering if that is necessary or if there's a reference we can pay out to rules or any other specific definition.
Okay. Yes. On page 2, this is our certification language. Upon receipt of an application from a recovery residence in the state seeking certification, the Department of Health is to issue the requested certification if the following minimum standards are met. And here is our list. Excuse me. The applicant is certified as either a Vermont affiliate of the National Alliance for Recovery Residences or another organization approved by the department. The applicant demonstrates the capacity to operate a recovery residence in accordance with rules adopted by the Department of Health and in a manner that ensures person-centered care and resident dignity. The applicant shall fully comply with standards for health, safety, and sanitation as required by law, including standards set forth by the state fire marshal, the department, and the municipal ordinance. Once certified, the recovery residents, including the buildings and grounds, are to be subject to inspections by the department with a 10-day prior notice. The applicant is to have a clear process for responding to resident complaints, including methods by which each resident shall be made aware of the complaint procedure. An appeals mechanism within the recovery residence. A published timeframe for processing and resolving complaints and appeals within the recovery residence. And periodic reporting to the department of the nature of complaints filed and action taken. And the applicant will fully comply with 9 VSA Chapter 137,
Which we've
is
all
our
memorized.
residential rental agreement chapter and statute.
Okay, well, at some point, we probably should look at that a little bit.
It's dense. You know, you may want Cameron Wood, who is our attorney who deals with housing. He has the expertise on housing rental agreements. So he would be the best person to give you sort of a high level overview of what is in that section. I can
Because I know we're going to hear about this.
chat with him about that if you're interested. In subsection C, we have language that the certification cannot be transferred or assigned, and it shall be issued only for the premise named in the application. And then we have language about the renewal process.
Let's look at this. There are questions about this section. So these are the overall
requirements.
requirements. So if we're talking about that, this would be like an application that someone submits electronically or in writing?
It doesn't specify. I imagine the department would, in rule, sort of set up a process by which interested recovery residences would apply.
Okay, and then we're gonna get to timing here for the time within which the application would be reviewed and approved or not?
There isn't a time frame.
There's no time frame for that.
No.
Okay. Those are the kinds of things that you have to follow up.
Chair, I guess on that line where I can see the issue come up, that there is no timeline and response time. If they're already acting as a home, then you have to renew in. You don't want a situation where all of a sudden they're no longer certified because the application has been processed and the person has to be kicked out of the house.
Good point. Any other questions, thoughts on that section? Oh, I'm sure we'll hear, and we'll also, as we go through any markup, we'll. Go ahead.
Okay. So we're on subsection D and the renewal. Annually, the recovery resident seeking renewal of its certification is to submit an attestation to the department that the residence continues to maintain its certification either through VTAR, the Vermont affiliate of the National Alliance for Recovery Residences, or another organization that's approved by the department.
So then we want to hear from NAR, what they have for reviewing the annual certification. Yeah. Okay.
This is all new language.
Yes, this is new language.
What are they using now to guide their creation of these recovery residences? I'm looking at 18 PSA 4812.
Well, so right now there's not a certification. So there could be recovery residences. There are recovery residences that are operating. They have to follow 4812. I would guess many have a relationship with VTAR. But there is no, I mean, this is a voluntary certification process, but right now that just doesn't exist.
Got it. Thank you.
Rulemaking. This just gives the department rulemaking authority to carry out this section. Then we have reporting requirements. On or before January 1st of each year, a recovery residence that's certified pursuant to the section is to report to the department data from the previous calendar year in consultation with VTAR or the other organization approved by the department. So the recovery residences are reporting to the health department on the number of residents served, the average length of stay at the recovery residence, any exit or transfer of a resident by the recovery residence, and the asserted basis for exiting or transferring that individual, the number of residents who gained or lost meaningful employment during their stay at the recovery residence, any budgetary needs, any other information the department deems appropriate. And then we have on February 1st of each year, the department aggregating this data and providing it to the General Assembly. Okay. So that is the certification language. And now we're switching to this section 9. This is existing law, and this is language about what conditions have to be met for a recovery residence to exit or transfer an individual. We have some language, some notwithstanding language. So again, we're in Title 9. We're in the chapter related to rental agreements. So 4463, we're not withstanding language that prohibits a landlord from denying a tenant access to possession of the tenant's premises except through judicial processes. This is already current law. You're notwithstanding the length of notice from a landlord to terminate a tenancy for failure to comply with the agreement or for illegal activity. And in 4468, you're notwithstanding that a landlord may bring an action against a tenant if the tenant remains in possession after the termination of the rental agreement.
So we could, Cameron would on this part too.
He might be able to give you a little bit more context on those three, but the work that was done 2 years ago, the committees did receive an overview of the different landlord tenant obligations. And these three specific items were set aside for the purposes of recovery residents. So otherwise, the landlord tenant requirements apply except for these sort of three specific items. So a recovery resident can only exit or transfer a resident if the following conditions are met. This is a very dense section. So first, the recovery residence has developed and adopted a residential agreement. And then we have a lot of information about what has to be in that residential agreement. Under existing law, it has to contain a written exit and transfer policy approved by VTAR or another certifying organization that has been approved by the health department. And that policy itself has to address the length of time that event will be held in the event of a temporary removal of an individual. It has to establish the criteria by which a resident can return to the recovery residence in the event of a temporary removal. And it has to ensure that a resident's possessions will be held not less than 60 days in the event of permanent removal. Also in this agreement, there has to be an explanation of program rules and expected residential social standards. That's new proposed language. Current language, it has to include designating alternative housing arrangements for the resident in the event of an exit or transfer, including contingency plans when an alternative housing arrangement is not available.
So, yeah, please, I have a question first. I'm sorry, that's you.
Oh, go ahead.
So just, this is the second question I'm asking about levels. So there are 5 different levels here we're talking about. And so if we're gonna have this blanket coverage for those who are in acute toxicity, that's an interesting thought. But okay, so just that all levels are affected here regardless of where the individual is. So,
Yeah, our definition doesn't distinguish currently.
yeah, I know, it doesn't distinguish. That's why I asked that earlier and now I'm coming back and reinforcing it. So, interesting question. Senator Gulick, Senator Cummings.
Thank you, Madam Chair. Expected residential social standards, is that a term that already exists in statute or is that no? Okay.
Yeah. We can invent our own social standards.
I was just curious.
Just say please and thank you.
Not a defined term.
Okay.
No, just as I remember, housing worked on this. I was there years ago. And somebody was in a residence, had a relapse. He got accident, he's out. And ended up homeless and bad things happened. I think he ended up deceased. So you can't be in a residence and be using because that puts everybody else at risk. And it's really trying to find that balance where, but I'm wondering if there is alternative housing available.
Well, this is one of the issues that we have here in looking at the different levels of recovery. So, you know, if you're in this level residence and you relapse, is there a place to capture you? Is there a place where you can go that's at that other level that get the help?
There isn't a bed available there.
Then we've got to sort that out.
Then what happens to you? You can't stay in the recovery house using.
That's one of the problems that we're trying to solve with this, but then we're also trying to make it systematic. And I think Department of Health may help us with this one. It's good.
Okay. So we're still talking about what is in that residential agreement that recovery residences must have in order to be able to exit or transfer a resident. The policy has to describe the residence's substance use policy, which shall exempt the use of valid prescription medication when used as prescribed. It must indicate that by signing the agreement, a resident acknowledges that the recovery residence may cause the resident to be immediately exited or transferred to alternative housing if the resident violates the substance use policy. New language, regularly refuses to engage in services or programming, commits a crime, engages in theft, as mentally or physically interfering with the recovery of other residents, or engages in acts of violence that threaten the health or safety of other residents or recovery residents, staff. So we have a mix of existing language and new proposed language here for what would be appropriate for exiting or transferring somebody to alternative housing. In subsection B, the recovery residence has to obtain the resident's written consent to its residential agreement, and that has to be reaffirmed after 7 days. So initially, when the person comes in, the recovery residence gets that initial written consent, and then 7 days later, they have to get it again. And there's a lot of conversation, I don't know in which committee, in one committee, about how it's there's a lot going on for somebody who's entering a recovery residence, and after they've had that 7 days to settle, it's appropriate to review the policy with them again. The resident again, we're going back to what's in the agreement. If the resident violated substance use policy in the agreement, if they regularly refuse to engage in services, commit crime, engage in theft, are mentally or physically interfering with the recovery of other residents, engage in acts of violence that threaten the health or safety of other residents or staff, that would be one of a ground for removal. And also that the recovery residence has provided for or arranged a stabilization bed or alternative temporary housing. So those are the grounds, the 4 grounds or criteria that have to be met in order to exit or transfer somebody. There has to be an alternative. The person has to have done one of the actions that is appropriate for removing them. There has to be written consent with the policy from the individual, and there has to be a policy. So we've just walked through those 4 steps.
Question, back to Senator Cummings' comment is, as I read that, or as you've just presented it, if the person is using and is causing problems, they can't be ejected from the house if in their agreement they don't have another place to go. So how does that affect the rest of the people in that home?
And it's not just that the person has another place to go, it's that the recovery residence has arranged an alternative. So it's not just I, the resident, have a different alternative, it's that the resident itself has established a place for the person to go.
And I could see, since it's voluntary, few people wanting to sign on to this because it makes them ultimately responsible for this individual, no matter what they do.
Let me just make one point of clarification. This section 2 is separate and apart from the certification program. Section 1 was the certification program, and to get a certification is voluntary. A recovery residence doesn't have to do this. But in current law, this section 2, a recovery residence does have to do all of these things. So this particular piece is not voluntary. We're still in this section. Relapse of a substance use disorder resulting in exiting a recovery residence shall not be deemed a cause of the resident's own homelessness for the purpose of obtaining emergency housing. That is existing law. And then the definition of recovery residence, we're striking through this language and we're cross-referencing the definition we looked at the top of the bill. So this has, we're using the same definition of recovery residence in both sections. We've already talked about this section 3. But it's worth going over because sunsets are always a little complicated. So 2 years ago, when the General Assembly adopted section 2, they decided that was a stopgap measure until there's more time for certification to be reviewed. So by striking through this line 11, what you're doing is saying that the section 2 language we just looked at is no longer a stopgap, but it is permanent law. It will no longer be repealed at the end of this fiscal year, but it will stay in statute. That's the effect of that strike through on line 11. And then what you are striking through is there was a report on recovery residents exit and transfer data that was also good for 2 years, but because you will be getting some of that information in section 1 as part of the certified recovery residence report, this is being allowed to sunset in subsection B. And if that is confusing, I'm happy to go piece again.
Oh, we'll get it sooner or later.
I know sunsets they're never straightforward. Okay, and this act shall take effect July 1, 2026. So that is it.
Questions? Good.
I know you did write this bill, but can you just maybe explain a little bit of what problem certification is trying to solve? Like why? Or should I wait for a different witness?
Yeah, I kind of wonder if the other witnesses might be better. I'm sure with it sort of gives a certain perspective that this recovery residence has been vetted and is meeting certain benchmarks that are the state of Vermont has said is important to it. I think if you want a more in-depth answer, you might want to hear from the health department or from the recovery residents themselves.
Thank you.
So the other thing about this is it was written before the report came to us. So it was anticipating a report that we received this fall. And I'm going to find that report for us to put on our web page on recovery residents. And the other piece of it is that there was a meeting with the National Governors Association representatives and CSG, in the fall as Council State Government, or NCSL. So I got the wrong group. NCSL. I should know this because I was unfortunate. Anyway, we worked together with the administration to have the meeting in Waterbury talking about substance use disorder recovery. And so a lot of the information that came from that meeting will also inform this bill and should have also informed the report that we received. So we'll look at that. Yes.
So a lot of my questions, I think, are going to be answered by reading the report. I have a question.
I hope so.
Yeah, because I'm with Senator Gulick, and talking to some of the residents, the recovery residents. Are we going to talk to any of those individuals or no?
No,
Okay,
of course we are. Yeah.
you're the chair.
And we're gonna have Jeff Moreau come in, who also represents Vermont, NAR. And so, yeah, we can get folks in. If you have someone in specifically you'd like to invite, okay, do that. Yeah, there's a ways to go on this bill. It's like a shell waiting to be restructured.
But we still have recovery residents out there, right?
We do, but one of the goals here, from my perspective, is to have some coordinated system of care for people who are most acute and then stepping down and making sure that they don't go back to the same culture that caused their harm in the first place. So that we have that coordinated system of certified, and some are not certified, but at least we're trying to put our arms around it.
Like my only other question, and I know this is for you, Katie, but I'm just putting it out there. So if I forget, you all can remind me, but I am interested in, the data section that will have to be provided. Because it does say any other information that the department deems appropriate.
Right.
I'm interested to know what exactly that is, given the world we're living in right now, data and data privacy is extremely important, so yeah.
That's on the list. That's my point. Good. We won't forget that one. Yes. You won't forget.
I'll try not to.
Katie, is there anything else we need to know about the bill?
Not at the moment.
Not at the moment. You're gonna help us fix it.
I am. So I have to hop out to another meeting.
Okay.
I just wanted to check in when you need me back for the next bill.
Do you want Calista to give you a heads up?
Sure.
What we'll do is we'll try to get on to schedule at 10:45.
At 45. I'll just come back.
Yeah, well, but we'll see. But
Okay.
yes,
If they're running late, let me know.
Yeah.
Okay, thank you.
all right, so we have Emily Kruger here from Department of Health. And I know DOH has sent in some language and I shared it with Katie and we haven't looked at it as a committee, but it would be good to just listen to your testimony. Yes, ma'am.
Years ago, there was an issue with. It wasn't a recovery house, it was. a place that basically prisoners being released. And part of the deal is you don't use anything. And that was being interpreted to include methadone, similar drugs. Did we ever get that straightened out?
Good question for Department of Health. I think we did. That you can come back first.
Sorry, you just tried it out.
So disruptive.
No, you get back.
Good morning.
Good morning.
Thanks for having us this morning. Compared to my last testimony, last week, this one I'll do a little bit more reading because I just want to make sure I get the line points, covered in that.
I'm gonna ask you just to speak up a little bit. Sure. I got this thing going on behind me.
Will do. It's
I can hear you, but
I'm. So I do want to open this morning with one part of our strategic plan that was recently published in April is education. So wherever we are, we're going to work on definitions. We're going to talk about different systems, how they interact. So the one thing that I did want to talk about this morning is sort of because the word recovery is used in different ways in different spaces, just to offer up some context within that. So we have a visual on the screen in front of us, in front of you that talks about residential treatment, recovery residences, excuse me, and recovery centers. So just to give some clarification there, residential treatment are clinical and medical services. These services occur in a 24-hour, 7 days a week, 365 setting. They have on-site supervision. Vermont has 3 levels of residential care in the state of Vermont. We have the highest level, which includes medically monitored residential treatment that occurs at Serenity House and Valley Vista in the state of Vermont. Those are the organizations we hear often as part of that. So that's that high level medical detox and highest level of acuity.
Did you send this in? Do we have this? We don't have it on our webpage.
Yeah, it's there now, you have to read.
Oh, it's just right there?
Yeah.
Okey dokey. Apologize for interrupting.
Don't worry. The next level down is still high intensity. So high intensity is about number of hours and just sort of what the load of interaction happens with individuals in that particular setting, but it's in a clinically managed space. So they've stepped down from the medical need, especially in that heavy level detox, down to clinically managed. The next level, which we're excited about, which has only been around for the last couple of years, and we do have a new program that just opened in Virgins, is what they're calling low intensity clinically managed treatment. Much longer lengths of stay, different interactions with the community as part of that. Some individuals still working on their recovery journey, but still needs a little bit longer time in residential. Lengths of stays can be significantly longer. 45 days, 90 days as part of that mix. They may be engaging in employment as part of that particular service. They're engaging in their community, their local recovery center. So again, sort of a step down, sort of that high medical, then high clinical, and then low clinical. That's part of that. The one that's not on this slide that I think answers some of the questions that were just asked previously is they also provide a service called re-engagement beds. So re-engagement beds are beds if an individual has recurrence of use while in a recovery residence. So they are, substances that come back into play. They can step into a bed at either Serenity House or Valley Vista to sort of re-engage with their recovery journey as part of that. And then potentially, depending on the circumstances of what occurred at the recovery residence, then return to their bed there. They also may be assessed at that point in time, their engagement, well, maybe we need to go back up to one of those higher levels of treatment, but we do have a re-engagement space in the state of Vermont that allows for individuals with that may occur. And that is new in the last couple of years, and it was an investment by the legislature that started that program, so we're very excited about that. So that's our residential space, and again, it comes from a clinical and medical model. In the center of the image, we have recovery residences, which we're here mostly to talk about today. They are shared living environments that offer peer supports, assistance accessing support services. They may provide case management and outpatient related services. Vermont primarily offers level 2 recovery residences. We do have the NAR standards at the bottom, which we'll talk about here in a quick second, because there are different levels of recovery residence. And through the Vermont Alliance of Recovery Residences, we have adopted the national standards. At the bottom of that, you'll have levels 1 through 4. Level 1 being sort of the levels start at the lowest level of sort of staffing and resources provided to individuals living in those residences. So first level is peer run. So the house is essentially doing their own thing. When we move to level 2, which is our largest volume of current recovery residences in the state, this is where we have recovery support and staff and a staff monitoring structure. So their staffing is part of the organization, the vendor, before being one of the largest ones. So people with the roles potentially joining us today can speak very well to that particular space. We do have a few level 3s in the state of Vermont. So Jen is promising one of the level 3s in the state of Vermont. That again has a higher staffing level, really starts bringing in more of those life skills components and have connecting people to treatment on the as part of their services. And then level 4 really takes that to the highest level. Level 4 and the 3.1 low clinical intensity really in many respects have a lot of things in common. It's a place where an individual is currently residing. They're receiving clinical services. They're having, employment services, life skills. It's just what side of sort of what part of the continuum direction that's coming from a recovery directed space, or is it coming from a space? We don't have a level 4 in the state of Vermont. Right now, we have 3.1 beds that we currently invested in, but we don't currently have level 4. We have level 2s and 3s, and I think a couple level 5s. A recovery center. So again, the word recovery shows up in many spaces. Our recovery centers, we have 12 recovery centers across the state. They are open during the day for people seeking support in their recovery journey. Recovery service organizations offer a range of services, including recovery coaching, support groups. You're going to see things like AA, NA, things like that. Referral to services and other peer support. There are no residential services that are part of our recovery center. They provide a safe and substance-free environment for people in all stages of recovery. I think the most important thing about the system at large is that it's meant to be fluid and meet the needs of the individual at any given time. And people do, as this is chronic relapsing disease, that they move in and out throughout the life cycle. So the goal is to set up a system that has all those different intersections and allow them to use anything to as part of that. Next, we did speak a little bit last week, but just some overall background to refresh our memories.
I have a question.
Oh, I'm sorry.
So going to your point earlier, so you have those different levels, but in the bill makes no reference to any of those in the requirements for a recovery residence. And so it seems like there's a missing link. You said there's different levels, but when we look at the bill, there's no different requirements, no matter what level you're providing housing for.
It would be my hope the certification process through rulemaking would establish that we, as a state of Vermont, for example, could choose to adopt the NAR standard. So if we adopt those NAR standards, which, for example, Utah has for the voluntary certification that's currently happening, within that, as an organization presents as a vendor, and this is what we'd like to do and provide. They also have some choice. I'm a vendor that wants to provide level 2. I may not be in a space where I can provide level 3. But the criteria sit within the certification standards and that criteria is assessed as they go through that process. Just a quick background on the report, and there's some, I think, caught up in news presses. I am not going to steal P4's thunder. But as of October of 2025, we did have 8 organizations across the state, in 29 locations with 145 beds. And again, those beds were a mix of sort of 50-50 men and women. And there are beds also for families, women with dependent children, as well as men with dependent children.
Oh, the date is February 1st. Why did I think it was the fall? I don't know. Can't answer that. That's up here. It was cold.
Within those organizations that we have across the state, we do partner with VTAR, so the Vermont Alliance of Recovery Residences, that currently facilitates a voluntary certification process in the state of Vermont. And again, they have adopted the NAR standards, which is the national criteria that is currently adopted by most states. We did submit a report to the legislature previously about that, about overall an assessment of the current inventory of recovery residences, what the data collection looks like, and sort of what those expectations of that. We do have the certified recovery residence exit and transfer data report is due to Monica. For S-157, an accolade to recovery residence certification, they previously presented before the 3 pieces. So create a recovery residence certification process, establish data reporting requirements, and modify the exclusion from the landlord tenant law. We're seeking to create a recovery residence certification process, including specific requirements for the department's authority and role as a certifier that would be voluntary for recovery residences. It would require certified recovery residences to report specified data, excuse me, to the department, and the department to report that data to the legislature. And would also seek to modify the existing exclusion from landlord tenant law and eliminate the sunset to occur currently in July. The current state 4 certification in the state of Vermont, we've currently partnered with VTAR as part of that mix. VTAR doesn't, VDH doesn't oversee the certification process, but we provide oversight through grant agreements to the recovery residences that receive our funding. And again, that's a subset of the current ranks in the state of Vermont. There are no requirements for the residences to be certified. They can voluntarily pursue certification through VTAR. There are several reasons why a recovery residence would seek that. I do think that the landlord tenant law is certainly an incentive as part of that. Both certified and non-certified residences can receive funding currently from the department. The department does not have oversight over VTAR certification, but we are able to oversee compliance again with the grant requirements, which have not only expectations and required services and activities, but also has extensive reporting and financial aspects to that. The 24 of the 29 recovery residences are certified by VTAR and receive funding from the department. 2 out of the 29 are certified but do not receive funding from the department. And 3 out of the 29 do not receive funding and are not certified by VTAR, so are not there. It is our recommendation that VDH recommends that the legislature grant authority under this section for VDH to establish and oversee a certification process for recovery residences. And this is under 18 VSA section 4806. This will align with the way we currently structure our oversight of the preferred provider network, which is under the system. We are seeking, instead of the process proposed in S-157, the department recommends the legislature give authority to the department in 18 VSA section 4806 to oversee recovery residences. Through that process, the department would have the ability to establish rules for the certification and oversight of recovery residences, which obviously allows for stakeholder input and voice. Given the department, this authority will be more effective than specifying certification process and requirements in statute as currently proposed in S 157. There's markup that's being provided. The rulemaking process will allow the department to engage in the public residence community to establish the details of the certification process with flexibility to adapt that process moving forward. The legislature would also have final approval of any rule proposed by the department. I think for context of what that looks like operationally, implementation of a new authority like that, the purpose would be to achieve these ends. We would be looking to offer a state-based certification to recovery residences still on a voluntary basis. Certification would be based at a minimum on the NAR standards. The VTAR or another organization approved by the department would continue to assess compliance with the NAR standards, and the state would oversee VTAR or another organization approved by the department. State funding would be limited to state certified recovery residences. Such a program would incentivize recovery residences to obtain state certification through compliance with the NAR standards. We're looking to set a minimum standard.
That's a question that I have. What's the carrot? I know that it feels, if you're a resident, it feels like a stick to go through all of this, but what's the incentive to have this happen?
I think that there's a variety of things. I think that when individuals are seeking services, I think individuals naturally gravitate towards organizations that are certified or have some type of oversight with them. And they're looking for quality of services as part of that. I think the other trick is the funding that can potentially come to them as part of that. Right now, recovery residences have a minimum of 5 funding sources that move through the department right now, a combination of federal, Medicaid, state general fund, and special funds. That's a very complicated budgetary mix. So it would open up some doors, I think, in those particular spaces as well.
Right. So, and there's some decisions about preference for certified residents when grants are granted.
Absolutely.
Yeah. Okay.
Yeah. So this one today, I didn't want any particular. And the program would enable the public to understand the level of support offered by recovery residents and protect vulnerable individuals by ensuring access to quality care. That quality piece is a big part of that. It's a big reason for our treatment standards that support our preferred provider network, sort of in that similar space. And there are expectations that come to us, for example, from the Substance Abuse and Mental Health Services Administration, tied to our federal block grant and things like that. Also do have some expectations for us in this space. So, we are required, for example, to submit quality plans part of our overall existence. Over time, the department supports creating a unified system of certified recovery residences in Vermont, but would begin by further incentivizing voluntary certification by limiting department funding and the exclusion of landlord tenant laws to only certified recovery residences. So that's as those sort of
This is the first step.
yeah. Just checking on any questions, but I'm going to move on to the data collection.
No, go ahead. Good. This is great.
So the current state for data collection happens in 2 spaces. So the Vermont Department of Health is one of the few states in the nation that actually collects outcomes data for recovery references. So we already have a leg up on the national stage as part of that.
No, it's getting bad.
Sorry, is this a little loud?
It was just the beginning. It's gonna get worse. It's gonna escalate.
Where will the school kids
I
get?
know. They're having fun.
You get it when everybody's lined up waiting to go in to testify on the budget.
Right. Oh, you
It's
got
when
it.
the end of the hall gets
I know.
Will you be able to help me sometime with the landlord piece?
I can try that yes, I can, but I would bring others to help support that conversation as well.
I don't understand that.
I think the biggest piece within that is the fact it's about eviction, and the piece where individuals, when they come to a recovery residence, they're not only coming to a place to live, they're coming to commit to a common goal. So those individuals are coming to an organization, they're working on their recovery journey. And part of that, I think about equating it to my children living in dorms in college. When you sign an agreement, it's not only about living there, it's about your behavior. and what happens within that. So I was trying to give a real world example that sort of had the same thing. If my child was, doing something against the agreement they signed to, they also could be removed if they're not subject to that space as well. But again, they come into individuals who are, again, decided on moving through their recovery journey, have made a commitment. It's chronic disease, things happen. So I think that's the biggest piece of it. It's about the safety of the individual as well as the group. Definitely.
So we're starting data collection.
Okay, great. That was my question. So
Yes.
appreciate that.
So currently data is being collected in two spaces. Certification by nature has a data collection piece for that, from the application component of that, as well as this data along the way to maintain certifications. The Department of Health also, as part of traditional grants management, we're required to collect data that we think is relevant, as well as what may be dictated by the funding source. So there are things, for example, if SAMHSA, the block grant says we must collect this, we must collect this. If there is something through Medicaid investment or something comes in legislation. So that right now there's a lot of sort of competing but there's quite a bit of overlap with multiple sources of asking for information. We do require funded recovery residents organizations to collect and report outcomes data. That began in 2025. The department publishes a data summary with the information reported by recovery residents organizations. There is a link in the presentation at the bottom here that will take you to that report that's currently on our website. VTAR also requires certified member programs to report certain data to VTAR. That includes things like number of residents served. That's a very traditional, doesn't matter the program. We're going to ask you how many unique individuals you're serving. Percent of residents that receive peer recovery coaching or work connected to a recovery center. Average length of stay. Percent of residents that transition to stable housing. Percent of residents that maintained and or secured employment during their stay. Percent of residents that experienced relapse during the stay.
I have a question. Sure. So you're talking about secure employment, and one of the goals of Turning Point Center, which is non-residential, is exactly that. So how do you coordinate the residents with the non-residents? And so maybe I didn't get a job when I was here, but it doesn't matter.
We collect.
It's how is this information being used, I guess, when it's not a fit for the primary goal of the residents?
I think we try to use a multi-pronged approach, and different things work for different individuals. There may be an individual in the recovery residence, and whatever the services are happening there, that's where all the, pistons fire and everything's clicking. Yeah. It may be the connection they make at the recovery center. It may be something they make in their community. There's even faith-based spaces where that can occur as well. So I think that our goal is to be able, there's no wrong door. So no matter how you're getting in there, you can find a path to recovery that includes, social determinants of health. We're talking about housing, we're talking about employment, life skills, we're connecting to family, whatever that would be. So we collect data in all those spaces. I can't necessarily tell you for one unique individual what was causing, was it the recovery center's intervention that made that happen? Did the recovery residents? We collect that all as a overall bucket of data and try to, synthesize that information with our teams for our evaluation.
Correct. Is immigration status part of the data that's collected?
I will check on this. Go ahead.
Sure. So the bill that we're looking at requires a bunch of data collection. It sounds like you're already collecting that data. So does the bill, I'm just curious, is the bill really necessary, or is a lot of what we're talking about in this bill already covered elsewhere? And I heard you say at the beginning that you felt the oversight should be under modification to an existing statute. So I'm just trying to see what pieces in the current bill are or aren't being covered already by existing programs.
Wonderfully segue me to our recommendation. So the health department recommends the legislature eliminate the specific data reporting requirements that are within the bill itself. That the partnership between the health department and the certifying body work together to align and harmonize our data collection efforts in an effort to be comprehensive, but also to deduplicate effort to reduce administrative burden. And with the understanding that there's multiple sources coming in, that there does have to be some fluidity to that. Because if, for example, if another large federal grant came in, they could ask for something very specific and it wouldn't want that to butt up against legislation. So so essentially having faith that the health department and VTAR in partnership can create the world that you're looking for. Obviously, that reporting is still back to the legislature as well. We're just as interested in.
So should we put in that you will harmonize data collection?
You can.
I like that.
It's a verb that we're struggling with. So
Harmonize.
that was
We got
the,
musical people in here.
that was the word that we got to when developing the presentation. And again, Vermont, it's on the few stage already collects outcome data for recovery residences. We would operationalize that through grant agreements, including the agreement we have with the certifying body.
Take a break.
Yeah.
Take your time.
Oh, she's covering what I just asked process question for
Process question coming up. Go ahead.
being the new guy
Yeah.
here. So listening to the testimony and modifying an existing act. How was that actually done?
When we get to mark up on the bill. So after we've heard all of our testimony, then we'll sit with Ledge Council and we'll go through the bill and mark it up.
Another question I have, Madam Chair, is, I'm guessing that if you moving forward, perhaps if you, or maybe it's current, if you don't have the certification, will you still be able to receive Medicare, Medicaid? You listed like 4 different funding sources. Do you envision?
That was my question earlier. What's the incentive for certification? Because you're not gonna change if you're right now doing the work. But it will offer an improvement for quality outcomes,
Yeah.
systems connection, maybe favorability for certain grants. So that's what I think. Yeah. But I don't think it's gonna turn off. We're not gonna close down.
No.
The Department of Health will still have oversight overall.
We need recovery residences, so that is, and there's already a lot of wonderful partnership between them and VTAR. I definitely 2 residents, I don't know why this is happening at all.
I guess they just said when you're talking, you just said, take
But
it
it's dry. So I don't see that certification as a barrier to services. I don't see it as a barrier to organizations who want being interested in being recovery residences.
It's funding.
If anything, I think it would open doors in regards to funding.
That's what I was thinking
Yeah.
too.
Yeah, and if it's not right now, Medicaid covered benefits, right now it's supported by Medicaid investment dollars, so it's still paid through like grant agreements. It's not something that's paid through the Department of Health Access or
Right.
like a Medicaid claim, for example. So it's still grant based on. Thank you for giving me that break, and hopefully this will figure itself out here in a second. The rulemaking process itself could naturally develop a set of reporting expectations with that. And again, that'll be a partnership with relevant stakeholders across the state, so we could build that together. And again, we're looking for things that are meaningful and that we'll use. We don't want to collect data for the sake of collecting data. So I think some of those conversations on partnerships can really help us tease that out and create something that's effective and useful. Any questions about data before I move on to the then we're tenant laws, which would be. My kids are gonna watch this. They're gonna be like, "Oh, what happened to your voice?"
I want to know, I'm conscious of our
Yes.
time, so I just want to make sure that the last person is here today gets a chance to testify, keep going.
I'll be quick. I'm almost
And
there.
I know you'll be back. I know you'll be back.
This money chair, something.
Money chairs. Please get away.
So the last piece for the landmark town law and you had some questions about that previously. Again, we're looking to, remove the sunsets. And with some slight, and just some slight modifications to the language that has been presented. I think for the purposes of time, I would probably right to that piece because you did get some previously. The department recommends that the current exclusions be made permanent with a few modifications. The criteria for when a resident can be executed should be modified to ensure that certified recovery residents organizations are able to effectively maintain safe and supportive environments for residents by adding the following situations to the scenarios that might cause the resident to be immediately exited or transferred to alternative housing. The resident regularly refuses to engage in services or programming, commits a crime, engages in theft, is interfering with the recovery of other residents, or engages in acts of violence that threaten the health or safety of recovery residents' staff.
So let me ask this. This would cover all recovery residents or only those certified?
I do not know.
May not be able to answer that question, but it is a question.
It's a yes, and I don't know. I would not want to say I'm not authority on that.
State it'd be every.
I see.
I appreciate it.
I mean, you do limit to the exclusion to certified recovery residents, however.
The other piece that I do want to add to the mix, we are proposing that the exclusion should be limited to certified recovery residences as it currently is within the legislative framework. The last piece I have is our partners at DCF, who unfortunately weren't able to be here this morning. But DCF has also recommended a language change for the committee's consideration. Deleting 9 VSA, section 4452 B2. Relapse of substance use disorder resulting in existing recovery residents shall not be deemed a cause of the resident's own homelessness for the purposes of obtaining emergency housing. This was recommended by DCF since there is not currently a requirement in GA eligibility and is no longer relevant. DCF, again, they weren't able to be here today, but they more than happy to come and talk to you about that and answer any questions.
Thank you.
So just a quick summary, as part of that, we had 3 pieces, so certification, data reporting, and the modifications to the landlord tenant law. We are seeking to have authority granted to the Department of Health to establish and oversee a certification process for recovery residences. We're looking to remove the statutory reporting requirements and allow the Department of Health and the certifying body to come together as part of that process, to include the rulemaking process to allow our stakeholders to participate as part of that, and to finally to make the current exclusion permanent with some modifications into the landlord.
Terrific. Thank you. This is really helpful. And let's start to get our heads into what's actually in front of us. Appreciate that. And we will have you back. It would also be helpful for you to recommend others who you think will help us.
Thank you very much.
Thank you. And I do want to talk to you about my question from a long time ago.
And I have answered.
Okay. All right. I know. Everybody's been waiting for that one. I know. We all asked it. So we'll move on to Candace Gale.
Good morning, Madam Chair. My name is David Regal. I'm the executive.
Oh, wait, so you're not Candace.
I am a distant second stand-in for
Okay.
Candace. I serve as the executive director of Vermont Foundation of Recovery. Candace wasn't able to join today, so I am pinching
Okay.
on Candace's behalf. For the record,
David,
Yeah.
David, we can't see your name right now, so maybe state your name again for the record. Do we have testimony from you on our webpage?
You do. I'll be reading Candace's testimony, and then I will be available to answer questions from the committee as well.
Okay, so we'll let you go through your testimony pretty quickly, and then because we're now being handicapped for time, but we may have Candace or you back another time as well.
Yes, that sounds lovely. So for the record, my name is David Regal. I serve as the executive director of Vermont Foundation of Recovery. I'm one of the co-founders. We started in 2013 and we're the largest recovery residence operator certified in the state of Vermont. I was also a founding board member of VTAR, so it helped to bring VTAR to the state and establish that voluntary certification program. V4 was the first organization certified to national standards back in, I want to say it was 2018 or 2019. So this work predates COVID. And I couldn't be more thrilled to hear lots and lots of different people show interest, talk about, describe the system that we've been building for 12 years now in the state of Vermont in such articulate and passionate ways. So thank you for the time today. So I'll read Candace's testimony. As you can tell, I've been in this space for a very long time. I've been thinking about the system and supporting Vermonters for a very long time. And so I want to be the best resource I can be to the committee moving forward. And I live in Glover, Vermont. So I am a resident of Orleans County and, probably going to differ from what I read in Candace's testimony. So here we go. All right. Good morning, Madam Chair and members of the committee. My name is Candace Gale, and I am from Barre, Vermont. I serve as the Director of Community Relations for Vermont Foundation of Recovery, often referred to as V4. V4 operates 10 certified recovery residences throughout Vermont. This was Emily's comment about stealing thunder. V4 just opened our 10th home a couple of weeks ago in Fort Ethan Allen in Essex, Vermont. So that's exciting. It brings our number of individuals able to be served up to 79. Our homes are certified by the Vermont Alliance for Recovery Residences and support individuals in early recovery from substance use disorder. Thank you for the opportunity to be here today and for the thoughtful work the committee has done on S-157. I'm here to speak in support of this bill and to explain why the language in S-157 is important for safety, recovery integrity, and the effective operation of certified recovery residences. Recovery housing operates as a structured recovery program, not as a traditional rental arrangement. Recovery residences are not apartments. They are not shelters. They are peer-based environments built on shared agreements, accountability, and clear safety standards. Members enter voluntarily with a clear understanding of recovery-based expectations that support both their own well-being and the well-being of others in the home. Most members enter recovery housing at a very vulnerable moment. Approximately 62% of our members enter recovery residences from unstable housing. When someone enters one of our homes, we do not just simply hand them a key. We work with them from the beginning to develop an individualized safety net plan. This plan outlines supports, emergency contacts, re-engagement options, and next steps if challenges arise. This planning happens proactively, not after a crisis. Recovery residences provide structure, peer accountability, and support during a critical transition. The average length of stay is about 6 months. These homes are designed to stabilize recovery and help people move forward, not to function as permanent housing. I want to briefly explain why intervention is sometimes necessary because it's often misunderstood. In one example, a member entered a recovery residence after completing treatment and initially engaged fully. They worked, attended recovery meetings, and contributed positively to the home. Over time, their engagement changed. They stopped participating in required programming, repeatedly violated house agreements, and began taking belongings from other members. Eventually, their behavior escalated to intimidation that made others feel unsafe. This was not about relapse alone. Recovery residences understand relapse as part of substance use disorder and respond with support whenever possible. The situation became about ongoing behavior that interfered with the recovery and safety of others. In a shared recovery environment, disengagement does not happen in isolation. When one member repeatedly refuses to participate in programming or shared responsibilities, it erodes trust. It weakens accountability, and it destabilizes the culture of the home. Members in early recovery rely on consistency and predictability. When those elements break down, it increases fear and relapse risk for others who are still stabilizing. The language in S-157 recognizes that timely intervention in these situations is protective, not punitive. It allows recovery residences to act when an individual's behavior poses a risk to the health and safety of others in the home. Another example involves a member who entered recovery housing while actively unhoused and struggled with significant mental health challenges beyond what a recovery residence can safely support. Because a safety net plan was already in place, staff were able to respond quickly. The member was able to access a re-engagement bed through United Counseling Services while appropriate supports were coordinated. While exits occur, certified recovery residences do not simply put people on the street. V4 works with community partners to utilize re-engagement beds, stabilization beds, and other temporary housing options as appropriate. Importantly, relapse or exit from a recovery residence is not treated as the cause of someone's homelessness for purposes of accessing emergency housing. S-157 reflects how recovery housing actually functions. Recovery residences rely on shared membership agreements, not leases. Members enter with written consent to recovery-based expectations and safety standards. When a member repeatedly refuses to engage in programming, commits a crime, engages in theft, interferes with the recovery of others, or threatens health or safety, intervention becomes necessary to protect the rest of the community. Certified recovery residences operate under clear standards, policies, and oversight. The language in S-157 supports these homes in remaining safe, structured, and effective for individuals who are ready to engage in recovery. Recovery residences are one part of the continuum of care. They are not appropriate for everyone at every moment. S-157 helps to ensure these homes can continue to serve the people they are designed for while maintaining safety, accountability, and recovery integrity. Thank you for your time, your continued commitment to health and well-being of Vermonters.
Thank you. That's very helpful testimony. Did you hear the testimony from the Department of Health a little bit earlier?
I did.
Okay, good. All right. And so any thoughts that you folks have on their testimony and how it fits with what you are thinking would be helpful? You don't have to go through it right now, but as we dive into the bill a little bit more, that would be, we want to know that we've got folks together.
Yes. I think generally we're supportive of streamlining the bill to whatever degree possible. I think we would be happy to continue to work with Emily and her team to make sure we fully understand what they're proposing and can come to some agreements if there are questions in any different areas. But overall, supportive of what the department is proposing.
Terrific. Thank you. That's exactly what I was hoping you'd say. And that you'll work together with Emily and others. That's awesome. So questions committee. We're good. Thank you. This has been very informative and useful. And next time we would like to meet and have Candace in the room with us at some point, then we'll see how that goes.
Sounds wonderful. Thank you.
Thank you, David. Okay, we're good. So we're going to turn off S-157, but I think we're on a path to move this one forward. We'll pick up additional information and testimony and language that you have, and maybe whatever comes from further discussions. Okay? Okay. So we're going to jump head first into early childhood. We'll take a little quick hiatus, but we don't have a lot of time for hiatus. So if you need a break, take it and come back, and we're gonna move right into the bill page. You're in here. What are you doing? There's a press conference.
It's a lunch shift that with the insurance. These
You have to be there.
Yeah.
So, did you want
just another time to talk with you about. the
Yeah, we don't
provision.
have to do that. I don't want to take your time.
Yeah. We'll take you follow up.
I want a 50-page report.
Yeah.
Thank you. Thank you. Thank you both.
She had an emergency.
Thank you. Okay. So we are looking at 206. How big a walkthrough did we have last time?
You did have a walkthrough. It was sort of high level. So you could,
So, yeah,
I know you have a lot of witnesses.
that's what I was thinking. Maybe we could set you aside. I know that
okay.
it's something you don't like doing because you never get free time like
She's
this.
so sad.
If we could have, do we have,
You have a whole slew of people outside.
oh, well,
They don't
better
know whether
open the
to come in.
door
Yeah.
and let them know that. Yeah. Open the dam.
Oh, that's. Okay. I think she's gonna keep on her meeting. She would go with the bus. I don't know. If any chance that you do. Sounds good. Sorry.
Stranger.
Sorry.
Ally, why don't you just sit right there?
Well, we're first.
Yeah.
Sorry.
And you want others with you?
Emily will be with me. That's okay.
Okay, so we have a limit of 16 people. If you're not testifying,
I just.
We're back out.
the enforcer will be back. That the enforcer is here. Where's our vice chair?
We have,
I guess my bag is filled.
we have a 16-person back.
If we leave the door open, if it's quiet in the hallway, maybe we can stretch it a little bit.
Oh my God.
Sorry. Yeah.
Sorry.
Yeah, no,
Yeah, that would be good.
This chair, I'm telling you.
Let's do that. And then,
So
Are you
can someone get
testifying
Emily? Yeah, she and I. Take this one.
no, can't take that one, but the gentleman right there, if you could give that to her, that would be great.
I got a feet over here as well.
Okay, great.
We need a chair. at the
I'm
table.
back.
Van? Sorry.
Yeah, of course.
Back.
But, oh, listen, you haven't seen anything.
I can't imagine.
Oh, no, could.
If I just sneak behind.
Oh, yes.
Good practice.
No,
No.
especially now. But yeah.
I've been in the knees of more long years. Does this go?
Have you been up to?
How you doing? What you close to say? So just close that door a little bit, but you're still there. You're good. Okay, we're fine, right there. Oh, so thank you for being here. We did go through S206 with Ledge Council at a fairly high level. But we're interested in what's happening out with the childcare world. I know we did a huge lift, and thank you to Let's Grow Kids, and especially to you two and others who worked so hard. Sarah Kenny for one, and who worked so hard on all of that, and all of our childcare providers. So we want to know if it's having an effect, and then what your thoughts are.
Thank you so much, Madam Chair. Thanks a lot. For the record, I'm Ally Richards. I'm coming to you today as actually board chair and strategic advisor for the Let's Grow Kids Action Network. I'm joined by my colleague, Emily Tenenbaum. We're going to do about 5 minutes high level overview, just as you asked together. I'll start. I'll hand it off to Emily in a moment. But first, so I just want to sort of say, just as the chair has said, high level overview about what's happening in the 2 years since you all, thank you for your leadership, passed the historic Act 76 childcare bill. And I also just want to quickly, to set the stage, mention, so Let's Grow Kids had a 10-year time horizon that ended in 2025. So we sunsetted, having really addressed Vermont's childcare crisis, as we know. We're very proud of that work that we've done together. There is still more work to do, which is why it's critical that Let's Grow Kids Action Network is still on the scene with these amazing other early childhood partners, such as Building Bright Futures, First Children's Science, Vermont AYC, who is also in the room today, to carry the work forward. And you'll hear about the progress and the gaps, in a moment. So thank you all so much. So we have made incredible progress. It's very validating to be here and be able to share some good news. In the last 2 years, the passage of Act 76 have fundamentally fixed a broken business model where early educators can afford to make less, parents can afford to pay more by injecting the public investment in the system, and it is working just as we hoped. 100 new childcare programs have opened, 1,700 new childcare spaces all around Vermont. 400 new jobs have been created in the industry through that growth. That's just the tip of the iceberg. Many, many more with indirect and tertiary jobs created through that as well. And hopefully we continue to get better info on that workforce. Also, enrollment in the state's tuition assistance program, CCFAP, is getting out. The word is getting out to the people, and over 5,000 additional Vermont families are now getting reduced tuition assistance. So these are real numbers. I just wanted to point out a trend. More childcare programs have opened than closed in every quarter since the bill passed. So that means you all moved the aircraft carrier. This was a fragile, delicate system that was a bankrupting proposition. And because of the changes to Act 76, we are changing the trend. That's huge. I just always like to bring in some Vermont voices to this. So don't take my word for it. T. Lynch is a mom of twins, so I can really relate. Of Burlington, she was spending her entire paycheck on childcare. Now, because of Act 76, she's gone from $3,000 a month to $1,000 a month. So I just want to reinforce this isn't, a dime that Vermonters are saving. It's actually really life-changing for many. She can have a 2-career household now, which she wants to have and save for the future. Another example from the early educator side, Michelle Bishop is opening a new program in Addison that she could not have opened without Act 76, and even better, she renovated an empty elementary school and is using that for her program, and she has opened it, and now she's continuing to expand it. It's a huge success story. She would not have been able to do that without the sustainability of Act 76. So in Barrie, we have a family home, and these are also in your written testimony if you want to refer to this. Alexander Whitcomb, her Hope program now qualifies for tuition assistance of the families in her program. So one mom with a kid in her program is able to quit her second job that she had taken on expressly just to pay for that child. So I also want to say, while I love bringing those stories in, don't take the anecdotes, right, for just alone. There's really good data at your fingertips now, which I have to really commend you on your leadership for not just passing the historic transformation bill, but putting accountability measures in to make sure it was going well and we could continue to make course corrections, because this is what we do as policymakers in Vermont. And so in this case, First Children's Finance has a fantastic supply and demand study. It clearly shows the progress and the gaps. It's shown that between 2024 and 2026, we've had very large functional increases in capacity of childcare across the state. It also shows we are now meeting the need of about 40% of infants who are likely to need care have access, which is up significantly, but still 40%, 70% of toddlers who need childcare getting access, and 69% of pre-K students. Okay. So those numbers have all gone up, and it shows the work that we have left to. So in addition to the First Children's Finance study, there's a pre-K monitoring report baked right into the law. Thank you for that, for building bright futures. The key takeaways from their really incredible report that even has a dashboard right at the top. I highly recommend approval of that. One is that affordability improvements are really working. In fact, expand eligibility, higher CCFAP rates. These are getting out to folks. Vermonters understand they're eligible and are signing up, and it is increasing affordability for families. The other thing is that the workforce shortage. So this is why I think it's thank you for inviting us for an overview as you delve into this new frontier, this very important work of thinking about this workforce bill. Major takeaway from the monitoring report is that the early childhood education workforce shortages are the primary constraint to access, expansion of childcare workers. Despite the increased funding and the demand, staffing challenges continue to limit programs' ability to expand, especially for infants and toddlers. But I'm really excited to have sort of another transformative, creative solution to this that you all are grappling with. And finally, that program stability, yes, has improved, but it depends on the setting, the geography, the program type. It's not all equal.
as far as the stability that X76 has provided. So maybe a little longer than I thought. I get started and I can't stop. I'm very excited about this issue and I'm incredibly proud of the progress. And as you can see, there's work left. You have really good tools though, to continue the work. So I'm going to hand it to Emily, to introduce herself and just sort of finish the wrap up, especially in regards to how it fits the context of the bill you're looking at.
Great. I'm Emily Tenenbaum, for the record, the new executive director of Let's Grow Kids Action Network. And just because it's my first time ever in committee, I know I've been around the building a lot. First time ever formally in committee. Just wanted to introduce myself. I grew up in Southern Vermont, proud public school graduate of Hartford High School. Moved away and was very, very happy to move back with my 3 kids because of the promise of what was going on with childcare here in Vermont way before this was all reality in legislation. And I have 1 kid in childcare as well and 2 other kids in public school. So really parent advocate in this space as well. So from Emily's testimony, it's clear there's a lot more work to do in 2026. Just wanted to go over kind of what we're focused on as the childcare movement and the policy priorities. So protecting childcare funding will help drive Vermont's further success, strengthening our early educator workforce, which is what we're here to talk about today, and passing the CCE prevention bill. We also want to make sure we're increasing childcare access and affordability where possible, and fixing delays in fingerprinting and background checks for ECs, which are critical for safety and staffing. So we've provided the committee with a full briefing on the 2026 childcare agenda, both with the committee assistant here today, but also on your email boxes. Happy to go into more detail on any and all of those things as well, but just really wanted to be here today to talk about the critical next step of this childcare progress we're seeing. Just want to note that our policy agenda was written and released with our close partners at the Vermont Association for the Education of Young Children, Vermont UIC, with Sharon here in the room. It's the state's largest membership organization for early childhood educators. They're the experts that have been leading the ECE workforce over the past 50 years. And before your committee, Senate 206, not relating to licensure of early childhood educators by the Office of Professional Regulation. The elements of this bill are based on recommendations by the Task Force of Early Childhood Educators led by Vermont AUIC, and it was a multi-year feedback process, really important that it was industry informed and spent years really talking about what this industry needed and that how clear it was that this profession was really needing some recognition along with the supports. And this was led by Vermont AUIC. So the early educators were able to provide comments through the Office of Professional Regulation, and this feedback really shaped both the bill, but also the revisions from the 2025 bill, and that was all seen in that work last year. And I'm sure Sharon will be coming in at some point to testify, and we'll be able to be the expert on that. I just wanted to note today here as I close up, long-term public investment is helping programs grow and improving quality of early education. So both for educators and for kids. To meet the needs of families, we need thousands more educators. We can't get the access we need if we don't have the staffing and the people in the room and that they're qualified and well supported to be there. It really, our progress depends on strengthening that workforce, and the best way to do this is pass this ECE profession bill along with a variety of other tactics. So by recognizing ECEs as the skilled professionals they are, I see one in the room with us today that we worked with, we're giving them the clear and supported career paths they need both to enter the profession, stay in the profession, and make it possible to do that recruitment and retention we need to do. Vermont educators have been calling for this recognition for years because we know better qualifications leads to better outcomes for kids. Why we're all here for kids. We need to make sure we back up with a strong system of support, including scholarships, student loan repayment assistance, and apprenticeships, all of this to make sure that early education is a more viable career here in Vermont and will help our childcare system expand. So in closing, ECE profession bills, workforce informed, workforce strengthening, and a legislation that we all support. Thank you.
So you support the bill?
We strongly support the bill, and I found someone who talks faster than I do. So
yeah, sorry.
So listen, I thank you for that. And Emily, if you can send your testimony in to Melissa, and we'll get it up on our webpage.
I think it's already, yeah.
I don't have the, do we have the written? On the written.
I might have done a little few anecdotes there, but it should be in.
Okay, it's basically the agenda. It's hard.
Yes,
I got it.
it's
Okay.
our one testimony as well as our policy agenda is also there, Senator.
Okay.
She can train me in a lot of things, but not to talk.
Okay.
I'll try my best to work
We're
on
good.
it.
We're good. I just don't like to lose anything because then when we go through final markup or someone's reporting the bill, we need to have the data and information to do that. Questions?
Not a question, just a desire. we're hearing a lot about kids entering school that are not ready to learn. We have behavioral issues. Is anyone tracking? I assume that if you go through a trained daycare, you know how to walk in a straight line, which is what my grandson learned in kindergarten. Is anyone tracking whether or not kids that go through these programs are coming in better ready to learn?
Yes. Yeah, so I would talk to Dr. Morgan Crossman, Build Bright Futures. They are the ones that really are the data experts, but I would say, Senator, the data is very clear. For a decade working on this issue, we grappled with how to talk about quality and what to put in as like the proxy measure of simple way to talk about quality. And when it became clear, the research was so abundant, the level of preparation and support of the early childhood educator in the room was the single indicator, with deep research on how well that kid was going to do in the program. So this is what we talk about when we talk about quality. And then yes, when you have quality equals, right, at like anything center, right, the human in the room supporting that child's growth. And then right, it leads to the outcomes, which also are well researched. So the good news is what we're seeing in Vermont is very good outcomes and increasing for kindergarten readiness. And it's because of the quality and level of preparation support continuing to grow in that 0 to 5 space. I'll also mention equality is not enough, which it should be, right? It's also the thing that is determining access, right? So that's why I think we're here before you saying the next huge movement in the evolution of this work we've done together is this workforce piece for quality and for access.
Okay. Thank you. Thank you very much for your testimony. I'm kind of, I was gonna say knee deep, but I'm really up to here in education stuff right now. And as you probably know, we have a really complex governance structure in the state of Vermont, and our policy, our sort of bifurcated policy systems are complicated and complex and hard to maneuver. And I think they're making education reform difficult right now, at least as far as I'm concerned. So when I think about what is proposed here, I really appreciate the Office of Professional Regulation and their Sunrise report, and it's incredible work. Did you ever consider having the Agency of Education sort of fold this into their pre-K-12, the work that they do already?
So the main answer I will say is I highly recommend you talk to Sharon Harrington of Vermont NYC, deeply, expert and leaders on this, and can tell you more detailed explanations of yes. There's been a ton of thoughtful work of probing what is the right way to do this, national work, Vermont consensus work with the Office of Professional Regulation. And what I believe emerged was the most practical straight line that does not have duplication for a variety of reasons that you can hear more of from those folks. But, it's a very much, as you dig into it, it doesn't duplicate what already exists. Mm-hmm. And it brings in an entire new 0 to 5 world that has been otherwise ignored, right? So, and there were very good reasons for that I just don't want to. I don't want to elaborate too much on because other experts are.
Got it. And we've got folks on the list to come in and testify. And if you have specific individuals, then we will ask them in. But so right now,
I'm just curious what.
Yeah, no. We've got it. This has been ongoing for a long time.
Also, the variable desk about that.
Yeah, no, it's between DCF and or CDD and AOE, it's a constant dialogue and how do we fix it, whatever it is. So thank you. Thank you both. It really is good. We're just getting our, we're just getting started. And Shannon M. Evans Folsom is here from JP. I thought that he might be the JP.
Yay, JP.
See if I can squeeze in here.
And just FYI, folks, I know that there are 2 people who were wiggling in their seats, but that's something to go to, but we're going to finish this bill, and S26 was on our agenda to look at for the first time, so we will get to it. We may not do everything that's here today. Look at that. Welcome.
bear with me while
Okay.
I get my testimony pulled up while I work on logging back into this. I just want to briefly introduce myself. My name is Shannon Evans Folsom. I'm the child care manager for JP Resort, and I'm also a resident of Newport City. I've been working at JP since 2013, starting in ski and ride school. My time there ultimately led me to a career in early childhood education since the snow kept melting and I really needed a year-round job. I earned a master's degree in early ed from Champlain College, achieved my pre-K teaching license, and joined the child care department at Jay as a teacher in 2018. And now I am the child care manager, and I've served that role since April 1st, 2022. It's a really weird day to get a promotion. It's also a very unique position at an intersection of private business and public service. My responsibilities include recruiting and retaining qualified staff, ensuring compliance with child care licensing regulations, and coordinating both recurring and non-recurring services. Our employee and local resident center operates year-round, serving children 6 weeks to 5 years old. We also offer an Act 166 UPK early learning program. That's what we call recurring care. We see these families every day and serve them for multiple years, even multiple siblings. For non-recurring or resort drop-in care, we have an additional licensed space in our ski and ride school building, which I operate mid-December through the end of March every ski season. This space serves children 0 to 4 years old. As of this writing, I have sent out 146 enrollment packets for the 2026 season. And by the way, we haven't hit President's Week yet. Furthermore, when my year-round program is fully staffed, I have 23 spaces for infants, toddlers, and pre-K children that I can offer to our employees and our local residents. Our department has the opportunity to touch the lives of very many, very little people. And my team and I take that really seriously. There's a lot to know when you work with these little people. For example, it's completely developmentally appropriate for toddlers to enter a state of conflict every 20 minutes. That's 3 times an hour, every hour.
Sounds like the Senate.
So you're familiar with this. You can complain. No. Also, as much as 90% of the human brain develops by the age of 3. And in 2010, it was estimated that young children spend approximately 12,000 hours in group care and institutional settings before they go to school. Early childhood educators make those 12,000 hours meaningful, enriching, and full of play, love, and connection. So that brain that's growing so rapidly from 0 to 3 is nurtured with language, art, music, relationships, and so much more. This helps set the foundation for a young person equipped with self-regulation and a grounded sense of self and community. As a center director, I get to invite new people into this career and provide a valuable service to our local community and our guests. When I was interviewed in fall of 2025 by First Children's Finance, I said that offering childcare wasn't a luxury, it's an investment in our entire region. I meant that. Childcare allows our local community to get to work, and a good number of jobs in our region are connected to the ski resort industry, which contributes to our state's economy. Jay Peak Resort employs on average 550 people year-round. We also experience huge influxes of seasonal employees, and those folks need childcare too. I know, they call me. And yet, there remain huge barriers to recruiting and retaining a quality workforce in early childhood education. So this is where the licensure process envisioned in S206 comes into play. Licensure provides a clear pathway for a career with longevity and value. It creates workforce retention, which improves access to childcare for families. So another way to think of it is this: I can have my driver's license and I can drive my own kid to school. Okay, I can even help drive my neighbor's kids to school, but I definitely need a CDL before I drive the whole school bus. Okay, so this is where you folks come in. You have the opportunity to help minimize these barriers. Please carefully consider how licensure for early childhood educators and home providers could help evolve this profession. We deserve a career with respect, longevity, value, and fair compensation for our unique skill set and knowledge. I would love a better hiring pitch than, we don't do this for money or respect, but we have a lot of fun playing all day. Right? And if nothing else, please become champions of the educators that work in childcare. Because if we worked in daycare, we would do this. Yeah. All right, that was a great 10 hours. See you guys tomorrow. No. We work in childcare. We teach children. We support families. We honor their messy and lovable lives, and we do it with our whole hearts. Madam Chair, fellow senators, thank you all again for your time and your consideration of my story. If there's anything further I can offer, I am at your service.
Thank you, Shannon. It's great. Really good. We have your testimony, which is even better. Yeah, you did it. And congratulations on all your work. I mean, you have longevity in this, and you've got training and also the experience to help us understand what we're looking at.
Absolutely.
Really appreciate it. Yeah, good. And you do deserve respect. We get that. Yeah. All right. Questions, committee, any for Shannon? So let me ask you this question. Since the passage of our bill, I forget the number, it's always Act 76, yeah. Have you seen a benefit as a result of that?
Absolutely. So part of Act 76 was boosting subsidy reimbursement rates up to 33%. And our year-round recurring program where we serve members of our local community, we are able to accept CCFAP money because we are a licensed program that follows all the rules and, jumps through all the hoops. So that was an instant bump to the revenue that I was able to then bring to our leadership and said, hey, look, you wouldn't have this money if you didn't have us. So our wages need to go up. Come on.
We got it.
So it's a fight that I've been fighting a long time.
Thank you. Terrific. Thank you for coming in today, and we've kept you from the mountain, but
That's okay.
the bigger mountain.
Got this one out.
It's good. Thank you.
Thank you for your time.
So we're gonna hear from Danielle Harris from the YMCA.
Sure, yeah, I can switch it in.
Thank you.
All right.
Welcome.
Thank you. Thank you for having me. I don't do this on a regular basis, so I'm going to read my testimony.
That's just fine. I'm gonna make sure you introduce yourself for the record, and then I think we had your testimony.
We're going to submit it after.
Yeah, we have.
Oh, you have it?
That's it right here. Yeah, this is great. So go right ahead.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. Thank you for having me. My name is Danielle Harris, and I'm a Senior Director of Youth Development at the Greater Burlington YMCA. Thank you for the opportunity to speak in support of professionalizing early childhood education in Vermont. The Y shares support for efforts that bring greater clarity, consistency, and professional recognition to early childhood workforce, as these educators carry enormous responsibility and they deserve pathways that reflect the importance of their role. That said, while the Y supports the goal of professionalism, we'd like to share a few concerns we have with this bill, as well as offer some suggestions, changes. Our concerns largely focus on demographics and workforce challenges, proposed licensure fees, and quality of care equity. The Y, like so many other programs and professions in the state, face significant workforce shortages. Each year, we seek to fill on average 4 full-time teaching positions and 4 floating positions in our downtown location. Most applicants are not qualified. Many have little or no experience or limited education. The average time to fill a position is typically 3 to 6 months, sometimes longer. Though our programs have retained well, we've had 2 applicants recently who were technically qualified for our positions that were open, but unfortunately never returned emails about an interview. We see our challenges in hiring as a symptom of the demographics in our state. As you're familiar, Vermont is graduating fewer high school students each year
and we have a limited number of college graduates staying in Vermont and entering the workforce. The Vermont Futures Project reports that Vermont needs to add 13,500 workers annually to improve affordability and ensure maintenance of essential services like childcare. Given Vermont's worker shortage and shrinking graduate pipeline, new barriers to entry could intensify existing workforce challenges, including for qualified educators moving into the state. Additionally, this bill does not go far enough to be inclusive of early ed workers that have significant experience in the field, further limiting their upward mobility within the profession. For instance, we have an assistant teacher who's worked at the Y for well over 17 years. She's a popular staff member who's great with kids and should be a wonderful head teacher. Unfortunately, she does not have a higher education degree and is therefore disqualified from consideration whenever we have an open teaching position. We've asked her whether she'd like to go back to school, but she's expressed concern and is intimidated by the process. With 3 children and limited funds and time to dedicate to workforce, she's opted to stay in the field at a level that is below her proven ability. Our suggestion is to examine competency-based pathways to licensure. We know that experience and demonstrated competencies often equal or exceed degree attainment. This is evident in section 6221C. However, the language is vague on which competencies acquired through experience would count toward credit, and whether the provider seeking credit would still need to pay for the credits from the educational program. We would prefer that the Office of Professional Regulation create a parallel non-degree pathway that evaluates all competencies and experience of providers to obtain licensure. In addition, OPR or the proposed board should have structures in place that enable new residents as quickly as possible to enter the field. The biannual licensing fees suggested in the legislation are disproportionate relative to typical PCE wages. For many of our staff, the fees could be approximately 30% of their weekly pay. While issued biannually, each time renewal comes up, this amount becomes burdensome. Our suggestion is that the team would like these fees to be reduced or otherwise allow for providers to access special funds to help offset the cost of renewal. The Y understands the vital importance of high quality care and accessibility of childcare, which makes home-based care an essential place and piece of the early ed landscape. However, we're concerned that the decrease in quality as it pertains to home-based providers outlined in section 6221 B4, whereby the family childcare provider need only to be in good standing with the Child Development Division as of January 1, 2029 to qualify for licensure. We'd like to see parity and equity in the expected quality of care across the early childhood education sector. We'd like to set the expectation that all providers, whether home-based or center-based, meet the same standards for licensure. We would anticipate a non-degree competency-based pathway to help with this regard as well. In conclusion, the YMCA supports and commends the committee's intent to elevate early childhood education as a profession and to bring clarity to requirements that are currently difficult to navigate. As a workforce is formally professionalized, we respectfully urge careful consideration to experience-based pathways, the minimalization of financial and administrative burdens, and policies that ensure high-quality care across the full spectrum of providers. Thank you for your time today. And if you have any other questions.
Thank you. I mean, you've opened up a whole discussion here with your comments around experiential licensure. I know that's been a discussion in other areas, including, educators who have experience, but don't have the education credentials. So this will be helpful. And we'll have to hear from others about this and what the thinking is currently through AOE, CDD, and OPR. To use all my little acronyms.
I'm with you.
You got it. You got it. So, questions for Danielle?
I just agree with you a lot because even in our industry, there's some people that don't have the credentials, but they're so talented and so smart. And so I know that there are individuals probably in the fields that can actually do this job. So the licensure process is a concern of mine.
Yeah.
So I want to express that.
Yeah, I want to be clear. I don't think we should minimize qualifications or get rid of them. I just want to support those staff that have been with us for so long that just are older, like myself. And if I was told I had to go back and get a college degree right now to do what I love to do,
And I'm certainly not against
Yeah.
education either. It's just that there are certain individuals out there that you want to keep.
Absolutely. Like this one I talked about.
Yeah, no, and it's an issue of who's there right now as compared with who's coming in in the future and what we can do to build workforce. It all fits together, so.
So do you think grandfathering would work, solve that problem? Possibly.
Maybe. Yeah.
Yeah. Cool, thank you.
Yeah, thank you very much for your time.
I'm looking at our clock here and I'm wondering OPR, what your thoughts are at this point.
How long does the committee have?
Oh, well, we have theoretically 5 minutes. Because we have another bill that we want to just take it under wraps.
So, what I'd like to say to the committee is, please, can we come back for the record, Lauren Hibbert, Deputy Secretary of State. I have with me Jen Colin, Director of the Office of Professional Regulation. We're really, really excited to testify in front of this committee. We would be honored if we could be given more than 5 minutes.
Well, that's what I'm thinking, and it probably serves us well to have that.
Yes.
So let's do that. Let's reschedule, have Calista put you up first thing next time. And because we have a number of other folks coming in as well.
Okay, thank you very much.
Right, and I did want to get to this other bill simply because people are coming in. We'll take a 2-minute break and then we're gonna go. We won't take we can't take a 2-minute break. And if they-
That's what it says.
I know how to.
It's actually
Really great.
Thank you.
I'm the new. It's 10 minutes. No, you're fine. It's great.
We'll wait for Anna Summerly to come in. They'll decide what we're gonna do.
Yeah.
Yes.
All right. Hawaii.
The
Okay.
other day wasn't.
I'm just getting.
Fresh recipes.
Oh, right, I know.
With my.
She figured it out. Wanted.
Because.
Good, well, I played with mine this morning.
I was here sitting right there, just the help.
It wasn't.
He didn't care about, he didn't have any concerns about safety.
We're not on the break.
No, I'm not leaving. I'm not leaving, madam.
I'm not, I
Right
can't talk
here.
now.
I have to be in House of Trucks in 1 minute. I'm wondering if you want, it's a 2-page bill, so I can do it real
I want to
fast.
do a quick, and then we've got the testimony that we're gonna take, and then we're gonna start it on the bill, we'll go back.
I can give you 2 minutes. Have you let Anna know, please, let's close the door. I'll be another minute.
That's 26. This is a short bill. It also may have a need to be looked at in another committee. It came from education. And then we're looking at it. And so my goal is to try to act on it a little quicker than other bills because it has to go back to education. That's why I'm being a little snarky.
Okay.
Here we go.
Hello again, Judy McLeod, Office of Legislative Counsel. So this is S-26, an act relating to prohibiting certain artificial dyes and foods and beverages that are served or sold in schools. It's a short bill. And it's a short bill, but it does a lot. In subsection A, in operating a school lunch and breakfast program under the National School Lunch Act
under the Child Nutrition Act, as amended, or selling competitive food. A school district and an approved independent school shall not serve as food or beverage during the school day containing water or more of the following substances. We'll look at the substances on the next page. I anticipated that there might be questions as to what is meant by competitive food, so I pulled the federal definition. Food and beverages other than meals reimbursed under the National School Lunch Act and Child Nutrition Act that are on sale to students on the school campus during the school day. So school foods provided for sale during the school day. So the prohibited substances are dyes, blue 1, blue 2, green 3, red 40, yellow 5, and yellow 6. No Fruit Loops. No M&Ms. Subsection A does not apply to foods or beverages sold or served away from the school campus. So a field trip, for example, it wouldn't apply to food provided or served on the field trip. Or at least 1/2 hour after the school day until midnight. So for example, if there is a sports team or if there's a band concert, those kind of events that happen after school, it does not apply. As used in this section, competitive food, we just went over what the definition is. And then we have a definition of school day. As it pertains to a public school, it's defined in current statute, and I didn't pull that, I apologize. And as it pertains to an approved independent school, it means the hours fixed by a school for instruction each day. There's nothing in statute until you set it here. So I will stop sharing, and I know that we'll have more time to have a conversation with me about this later. But you have witnesses, so I will get out of this seat.
Thank you. Thank you for your indulgence, and I know you're busy upstairs. We'll have a chat about that. Okay, so, Anna, did you want to come up first?
Yeah, I'm sure she sees.
Morning, everyone. Lines and members of the Senate Health and Welfare Committee. I'm Anna Suberling. I'm the environmental advocate with VPIRG, or the Vermont Public Interest Research Group. Thank you so much for the opportunity to testify on S26. So just because it's my first time in this committee this year, VPIRG is the Vermont Public Interest Research Group. We represent more than 20,000 members and supporters across the state and every single legislative district in Vermont. And our mission is simple: to protect Vermont's environment, climate, democracy, and of course, public health. So that brings me to this bill, which we are testifying in support of. And I want to paint a picture of our food landscape really quickly and then talk a bit about the bill. And I'll start with something basic, and that our food is making us sick. Most of what fills our grocery stores are ultra processed foods stripped of natural nutrients and packed with added sugars, sodium, unhealthy fats, and synthetic dyes and additives. These foods now make up an estimated 71% of the American food supply and a major driver of chronic diseases like heart disease, diabetes, and cancer. So many of these ultra processed foods that I'm talking about contain artificial dyes that offer no nutritional benefits and offer really concerning health risks, especially for children. Research has linked synthetic food dyes to hyperactivity and adverse behavioral effects. And yet many of these chemicals haven't been meaningfully reviewed by the FDA in decades. So that said, at a time when we really can't rely on the federal administration to hold powerful food manufacturers accountable, we're really looking to the states to do that. And Vermont has a long history of this, and S26 is a common sense place to start moving our food systems in a healthier direction. Importantly, this bill, I should mention, is also practical. The Vermont Agency of Education has publicly stated that they are in support of this initiative and would not have difficulty sourcing compliant products for their schools. And that's in large part because states like California have already started to shift the market with their policies in this area. So as you all continue your work on this bill, we would encourage you to consider aligning it with existing House legislation H260. We think it makes sense to align these two as they both relate to food safety and removing harmful chemicals from our food. So more specifically, H260 as it stands right now addresses other harmful food additives like brominated vegetable oil, potassium bromate, propylparaben, and red dye number 3, which are chemicals linked to cancer, hormone disruption, and reproductive harm. There are also a few other additions that other states are considering, which we would ask the committee to also include in this bill. Things like BHA, BHT, titanium dioxide, sucralose, aspartame. Happy to get you a comprehensive list of these things that we're asking you to consider, since it's a lot of chemical things here.
That would be great. If you did that, and then the obviously the states that are already.
Yes. Yeah, happy to. And so with that said, states are acting in this area and really demonstrating both the feasibility and momentum behind this initiative. So to sum up, S26 is really about protecting children and taking this important step to a healthier food system. NCURD strongly supports this bill and urges students to continue to work on this session. So just like the bill, I'm happy to keep it short and answer any questions you have now.
Questions? Good. Right. Well, we have folks to hear from. In fact, I have Scott Faber here today we'll hear from, but then we'll also hear from AOE, and it will go back to education. But thanks for your suggestions and looking at those other chemicals in H260.
Certainly.
Scott, welcome.
Thank you.
And but I have 2 committee members who have commitments outside of the building, so they're gone. But we are here.
Well, I have good news for the senator who was worried about Fruit Loops.
Oh, good.
That other countries are making Fruit Loops, including Canada, with just natural dyes. So students in other states are already still enjoying Fruit Loops, just without the synthetic colors that scientists are telling us are making it harder for them to learn. Just maybe step back. So I'm Scott Faber. It's an honor to be here before you. I work for the Environmental Working Group, and I also teach food and farm law at Georgetown's Law Center. Before I worked for EWG, I was the head of government affairs for the Consumer Brands Association, which is the food industry's trade association. So I've seen this issue from both sides, or many sides, if you will. And I just wanted to make 5 quick points. So one is that overwhelming science shows that these synthetic colors are making it harder for some of our kids to learn. We know that because of human evidence, observing what happens to kids when we feed them dyes. And we know that because of animal studies that show what happens to their brains when we feed them these dyes. Not only does it cause microscopic changes to their brains, but it changes the chemistry of their brains in ways that makes them inattentive. And that interferes not just with their ability to learn, but the ability of other kids to learn. So it's really important that we phase these dyes out of our schools so that our kids have every chance to succeed. The second thing I just wanted to say is that unfortunately, the FDA has not reviewed the safety of these dyes since the 1960s, 70s, and 80s, long before toxicological studies could tell us what impacts these synthetic chemicals were having on our kids' brains. The third thing I wanted to share is also unfortunate, which is that the FDA has no plan to review these dyes anytime soon. So they've published a list of chemicals they hope to review. These dyes are not on this list. The FDA has lost 20% of its workforce. Many of those people were the people who would have conducted those reviews. And so if we're waiting for the FDA to review these dyes, draw some conclusions, we'll be waiting a very long time. The last two things I quickly wanted to mention was that our school food professionals, as you've heard, are already able to replace products with other products that don't contain these dyes, in part because other states have taken action. Many states have banned dyes from school foods. West Virginia just last year passed sweeping legislation that bans these synthetic colors from all foods sold in the state. So food manufacturers, the food manufacturers I used to represent, are all now moving swiftly to remove all of these synthetic chemicals, not just from the foods that are offered in school, but from all the foods that you will get at Hannaford's or Shaw's or Stop and Shop or when you go for your groceries. And then the last thing I just wanted to mention is that not only is FDA have no plan to review these dyes anytime soon, unfortunately, the current system that we have for reviewing food chemicals allows new chemicals to enter commerce without adequate review. So since 2000, 99% of all that, I always hate to mention this right before lunch, but since 2000, 99% of all the new chemicals that have been added to our food have been approved for safety by the food chemical companies, not the FDA. And unlike pesticides, which have to be reviewed every 15 years by the EPA, there's no such requirement like that for the food chemicals we eat every day. So I would second Anna's comments about thinking about adding more ingredients to this list, more substances to this list. Just yesterday, the state of Indiana, their General Assembly, their House passed legislation that not only bans these dyes from school foods, but bans 6 other chemicals from school foods. Their Senate's taking it up tomorrow. Majority leader of their Senate is the sponsor of the bill. So I think there's room for more progress, especially in light of the fact that every state, it seems, regardless of which party's in control, agrees that some of these chemicals, many of which are not allowed in Walmart's store brands or Hannaford store brands, are still showing up in our school foods. So thank you.
Thank you. You did a great job of just telling a story. Beautifully done. And if you don't mind sending in your written testimony, Melissa will have that with questions.
How many products are we talking about?
In schools or in
schools?
Oh, there are, I'm gonna make sure I get this right.
Just a product.
No. They're in the, so it depends on schools have both the lunch line or what's called on the tray and the a la carte line, which is sort of, I went to high school in Massachusetts. I probably should admit that here, but we would have an a la carte line where you could buy other things, pizza, French fries, soft drinks, etc. There are about 1,200 products in the a la carte line. The lunch line is different because it's subject to a meal pattern. For those of you who served on the education committee or have worked in the school system, you know, most of those products are free from dyes already. It's really the a la carte line and the vending machine where the dyes are.
Okay, so it's not going to be a big struggle to lift this.
That's right. So if I'm a school food professional and I'm buying a lot of my products from Cisco or Aramark or Bon Appetit or the food service companies, they are already selling products without these dyes and other chemicals to me if I ask for them.
Okay.
It's the branded foods that might be sold in the a la carte line that would have.
I guess the industry's going to flip pretty quick once the states start doing this.
And
I would imagine.
Probably more than you need to know, but if I'm General Mills, I'm making 2 versions of all your favorite foods, one for you and one that's reformulated specially to meet school food standards, because we do set federal and state standards for sodium, for sugar, and saturated fats.
So the same has been said.
Absolutely, yeah.
Other questions? Sounds like we have a little work to do. Yeah.
Well, I'm hopeful that change is coming to FDA. I don't think it's coming soon.
Well, and just a quick question, is I know, well, unfortunately out of time, I'd love to keep you here for a while and just chat, but the EU
yes
probably already bans all this.
Yes.
And Canada.
Yes.
And so somebody's producing these dyes or sending them in to be mixed in with General Mills or others. And we're at the end of that pipeline.
That's right.
Right.
So there are about,
But they're,
2,500 chemicals that you and I are eating that cannot be added to food in the EU.
exactly. So, and the market in the EU is larger than the market in the United States.
And it's all the same food.
It's all the same food.
It's the same, exact same products. You wouldn't be able to tell they're different. They taste the same, they look the same. And I've done the science on this. It turns out they don't love our kids any more than we do. So, so it just, we kind of just lag behind on a regulatory front. So,
It'll help the beet industry, right? So we've got the beautiful color from the beets.
absolutely,
Yeah.
absolutely. That's right.
Thank you.
Yeah.
And thank you, V-Bird, for being in here and helping us. We'll move forward with this and get some more testimony, and have your recommendations for maybe some expanded inclusion.
Thank you.
Thank you. Oh, good.